So good evening and thanks to everyone for joining us today. We welcome you to the webinar organized by Haryana chapter of ISAR, and the technical partners for this webinar series is Jagsonpal Pharma, makers of Endorec, Devatron and Injection Mentate. So we present to you Endorec micronized Dynogest 2 mg in endometriosis associated with pain during IVF procedures. We have Divatron 10 mg micronized tablets of digosterone to improve compliance and enhance outcomes. We have injection maintained 250 and 500 mg of 17 alpha hydroxyprogesterone caproate to maintain positive pregnancy outcome. So a warm and hearty welcome to all the esteemed faculties and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. So to refer to this webinar in future, please visit our YouTube channel Jagsonpal Medical Insight. Now we invite Dr. Jyoti Malik, Chairperson Haryana Chapter ISAR and Director Roots IVF at JJ Institute of Medical Services Bhadurgarh to kindly initiate the program. Over to you, ma'am.
Thank you, Jagsonpal. Thank you, Manisha. And on behalf of ISAR Haryana, with my tagline of Prayas Evam Vistar, I invite you all on this Inspire and Ignite series, and this is series 16, where we would be talking on the focus on endometrium. So with the blessings of our President ISAR, Dr. Ameet Patki sir, and the Secretary General, Dr. Asha Baxi ma'am, we bring to you this series 16. Dr. Ameet Patki, can I have sir CV? Can I just briefly, the previous slide? Yeah. So Dr. Ameet Patki sir is Medical Director, Fertility Associates, Mumbai. He is Honorary Associate Professor, KJ Somaya Medical College and Hospital, and also consultant at Khar Hinduja Hospitals. He has been a Secretary General of MSR. He has been a governing council member. He has been the country representative to Aspire. And he is 35 publications with the national, international journals and many chapters in the books. And sir is a real person who we always look forward to, and whenever in need or whenever in doubt, he is always approachable. So that is our national ISAR president, Dr. Ameet Patki sir, and our Secretary General, another very sweet person next, Dr. Asha Baxi ma'am, who has been Vice President of the West Zone of Foxy and Joint Secretary of the National ISAR from 2020-21, and also a very easy to reach person and always happy to help sort of a personality that ma'am has. So with the blessings of our President and Secretary, I bring to you this series, and today we would be focusing on endometrium. So for that, we have a very wonderful person, and from Apollo Cradle, Dr. Tejashree. And our second talk would be by none other than Dr. Sachin Kulkarni on optimizing the embryo transfers. And then we would be having a panel discussion, which would be a case-based discussion by a very eminent person who really takes you through from basics to advanced, Dr. Pratik Tambe. So I'm sure we would be really enjoying this session on thin endometrium, and also the optimizing, how then to optimize once we have optimized the endometrium, how to optimize the embryo transfer. So I think we'll not lose time, and I'll straight away go to my first session with the chairpersons, Dr. Renu Chugh, Dr. Deepika Jindal, and Dr. Manju Khurana. These would be our chairpersons for this session. And our speaker is Dr. Tejashree. Can I have Dr. Tejashree's slide, please? Dr. Tejashree is a fellow in reproductive medicine from Sir Gangaram Hospital, and she is a senior consultant at Apollo Cradle Royale, New Delhi. Also, she is attached a consultant at the Gangaram Hospital, and she has reproductive medicine, fertility preservation, and high-risk obstetrics as the areas of interest. So, and a person, she is, since I know her from the group that the common WhatsApp group that we are in, and Dr. Tejashree guides each and every person on whatever little query they have on the on their day-to-day infertility practice. So a person, I think, who has her basics right and who would now let us know on how to prepare endometrium for frozen embryo transfer. So over to you, Dr. Tejashree, and we'll take the comments of the chairpersons at the end of your session.
Thank you so much, Jyoti ma'am, for the kind introduction. And I would try to share whatever little knowledge I have. So, good afternoon, everyone. My esteemed faculty for today's webinar, and all my dear friends who have joined. I hope I'm able to have justice to the topic and guide you through the endometrial preparation methods for FET cycles. So, as we all know, that the implantation is a well-defined and a precise process. However, it does require a receptive endometrium, a normal functional embryo, and a synchronized dialogue between the two. Now, with the robust, technique of embryo culture and PGTA techniques, we are provided with excellent quality euploid embryos. And what we are worried about most now is the receptive endometrium. So that is what we are going to focus today upon. So this is how a normal pretty endometrium looks like in a proliferative phase under the influence of estrogen. During the follicular phase, the endometrium proliferates, gets primed for the effect of progesterone, which comes after the ovulation in the secretory phase. And that is when the window of implantation opens under the influence of progesterone. This is the basic we all know. However, we have to know that there's only a specific period of time during which implantation is possible, and that's called as window of implantation. The structural chemical changes the endometrium undergoes to prepare for a receptive window of implantation is precisely a very highly complex process. And no wonder years back, Roberts Edward once wrote that the endometrium is the last barrier to the progress of ART. And that is why today we are here to discuss about how to go about it. As we all know by current research that 2/3 of the failure cases are attributed to the endometrium because we have beautiful euploid embryos available nowadays. And that brings us to, the FET cycles. We all know that all over the world, the FET cycles have risen. The number is just continuing to rise. Alone in Europe, the latest Tejashree data suggests that about 33.3% of all ART cycles are now FET. Despite so many of FET cycles, we are still yet to find a best protocol for endometrial preparation. Freeze-all is become a strategy nowadays, especially in cases like this where we want to reduce the iatrogenic OHSS, perform PGTA, or we find that there is a embryo endometrial asynchrony in the fresh cycle, or in non-synchronized donor recipient cycles, or where embryos and oocytes have been frozen for fertility. So freeze-all followed by FET has become a norm, and that's why we need to understand how best to prepare the endometrium. When we are looking for methods to prepare, we are aiming to find a method which will improve our implantation rates. It will ensure a safety for the fetus. That's most important. And would as few as cycles possible would be cancelled while using this method. So let's see what options do we have. We have all these options. The most commonly used till now has been HRT, though now we are shifting to more towards a natural cycle. So natural cycle could be a true natural cycle where we are using luteal support or not, a modified natural cycle wherein we are inducing ovulation with a HCG injection, or a mild stimulation cycle either with clomiphene, letrozole, or FSH. Now the last three are using natural estrogen, whereas in hormone replacement we are using a synthetic estrogen. Now coming to the HRT protocol, we all have been commonly using this protocol and are so well versed with this. We all have been using oral estradiol for the hormonal preparation of endometrium, also called as the programmed cycles. So the oral estradiol is started on the first, second, or third day of the cycle, not only to prime the endometrium, but also to suppress the spontaneous follicular growth. So we don't let a dominant follicle develop, because otherwise the progesterone will start, be there before we really want it to start. And that's why suppression of a spontaneous dominant follicle is also important. And for this reason, there are two protocols that have been suggested. Especially the fixed constant dose protocol is the most commonly used, because it leads to suppression of the spontaneous follicle that might grow. Now, there are fixed and incremental doses which are used. Generally, this HRT protocol, as we all know, can be used for all women, whether they are ovulatory, non-ovulatory, whether they are non-ovulatory because of a lower reserve or because of high reserve like PCOS. So this HRT can be used for both the patients who are ovulatory and non-ovulatory. Though the fixed constant dose can be started more for the ovulatory women, so that the suppression of accidental ovulation is better. The incremental doses can be used for PCO patients whose endometrium seems to be more sensitive to the low levels of estradiol as well. And also it is more physiological, wherein we give 2 milligrams per day for first 7 days and then gradually increase it to 6 milligram from 13th day onwards till embryo transfer. So this is the standard protocol that most of us use. However, now there are different routes of estradiol that have been come up. Apart from the oral estradiol valerate that we normally use, there is a transdermal 17-beta estradiol gel that we can use, and we can also use these tablets vaginally. Now, people have tried using this by all methods and found comparative results. However, when there was this international survey conducted in many of the fertility units, about 40,000 FET cycles were surveyed, and it was found that oral estradiol was most commonly used route. It seems to be convenient. Patient can just take the tablet and the blood levels can be easily monitored if required. It may not be done in every case, but oral route seems to be the most convenient. However, why are we even looking at transdermal and vaginal is because of their first pass metabolism, which is skipped. So they don't go into the liver, they are not processed by liver, they are directly going to the blood and reaching the uterus, which is very good for certain group of patients wherein they are obese, high risk for DVT, or they have mildly raised liver enzymes. So in such cases, we would prefer to use a transdermal or a vaginal route rather than an oral route. And we need to understand that even if we use that, the results would remain the same. And for that reason, we need to understand the conversions. So if you can, look at the last part of the slide, 0.75 oral micronized estradiol tablet is equal to 1.25 grams of transdermal estradiol gel, which is one pump of the gel, and which is equivalent to 1 milligram of oral or vaginal estradiol valerate. Usually now, once we start the estradiol, we call the patient after 12 to 14 days of administration, do a vaginal examination to find out the endometrial thickness, the absence of bleeding follicle. And then depending whether the endometrial thickness has reached the target of 7 to 8 mm, we start progesterone supplementation and time the FET. Now, some of the authors have always challenged that why to give so long, why to give 12, 14 days, 5 or 7 days, the endometrium might be ready. But it was found that if the endometrial exposure to estradiol was less than 10 days, it was associated with a higher miscarriage rate. And that's why at least 10 days of estrogen priming is required for a proper implantation and progression to a clinical pregnancy. Now, when the lower limit has been fixed, the higher limit still is up to 28 to 36 days. The estradiol can be given without compromising the reproductive outcomes. Now, there are certain patients who do not make endometrium in the dose that we have given. And we might have to either increase the dose if on day 12 or 14 we find that it hasn't reached 7 or 8 mm, it is 5, 6 mm, we can extend it up to 28 days. Also, we can change the mode of administration from oral. We can add transdermal in case we have to increase the dose, it is always better that we change the mode of administration. Like in our unit, we start with 2 milligram thrice a day oral tablet. And if we find it's inadequate, we add one pump with each oral dose. So it's 1.25 milligram additional estradiol that goes through the transdermal gel. Now, it also offers a flexibility. Just in case you're traveling and you don't want to do a transfer, you can extend estradiol valerate for another 4 days or 5 days without compromising the results. So that's another beauty of this HRT thing. However, in ovulatory women, a premature ovulation can lead to cycle cancellation, and this has been seen up to 7 to 8% of cycles of HRT. And that's why some people propose a use of GnRH analog before starting HRT in the previous cycle to suppress the HPO axis. Now, here we can give a depot injection of 3.75 leupride on day 21. Day 2, we start the routine HRT thing so that the follicle is not selected, or we can give a daily injection of 0.3 to 0.5 depending on the BMI of the patient and continue it till the day we start progesterone. Both these protocols have been described and shown equivalent results, but there are studies which show that even if we use GnRH analog or we don't use, the implantation rates and live birth rates remain constant. Now, this is something where we need to think, but there would be patients where follicular selection happens early and we might have to use a GnRH analog. Now, once the endometrium is ready, in HRT cycle, we need to add progesterone. We have to remember that in HRT cycle, we don't have a corpus luteum, and we are dependent only on the progesterone, which is given exogenously, not only for the preparation of the endometrium, but also for the luteal phase support, because there is no corpus luteum. For this, we have to understand what modes of progesterone are available with us. We have vaginal routes where various compositions are available: intramuscular route, subcutaneous, oral, and rectal. Vaginal administration is obviously distinct from other routes because it has a first pass uterine effect. The highest concentration is first reaching the uterus and then going elsewhere in the body. So that's why it has a distinct benefit compared to other routes of administration. And there is not much of a data available about the oral, subcutaneous, and rectal routes. So most commonly used is vaginal. Only in patients who complain of irritation or allergy or inconvenience of vaginal, then we shift to other routes. Normally, this is the protocol. Now, in vaginal progesterone administration, we have 3 or 4 options, but commonly we use 2 options. Bioadhesive gel, which comes in a dose of 90 milligram per dosage. We use it twice a day. Micronized progesterone tablet and capsule, 100 and 200. So thrice a day they have to be used. Another most commonly used thing is suppository. So vaginal micronized progesterone suppository, 400 milligrams twice a day seems to be a good dose. Though there is a paucity of data regarding the comparison of all these vaginal routes, but commonly used in our unit, we use 400 milligram suppository twice a day, and or adhesive gel 90 milligrams vaginally twice a day. Now, again, there have been n number of this studies which I wanted to show about the use of which progesterone is best and which gives better results. Here, I want to highlight this, RCT by Divine, which was done in 2021 with 1,060 patients, wherein what he did was a vaginal progesterone tablet, intramuscular progesterone in the dose of 50 milligrams daily, and a combination of both in the form of 200 milligrams twice a day, vaginal tablet, and every third day a 50 milligram IM injection was given. And here he showed that the highest, high clinically significant pregnancy rates were found in the combination of both. However, there was a criticism about this study, about the day the transfer was done and the positivity rate, and that's why this protocol never got attention. But what I wanted to highlight is that combination protocols are coming up. But recent in 2022, there was one RCT, but very less number of patients. Here, individual comparison of various protocols has been done. Oral dydrogesterone 20 milligrams twice a day, vaginal gel 90 twice, and even intramuscular injection is given twice a day. And then similar pregnancy rates were shown in this, but the numbers are very less in this study. Now, coming to the individualized luteal phase support, it is getting a lot of attention after a study which was done by Labarta et al. In 2021, because here they showed that there was a reduced pregnancy rate when the progesterone concentration on the day of embryo transfer was below 8.8. And they also showed next year, after the study demonstrated a certain cutoff, that rescuing such cycles by giving subcutaneous progesterone led to comparable pregnancy rates. Also, oral dydrogesterone shows similar result in other studies which were very recently conducted. So this is something that we have also given attention, and at our unit we do practice individualized luteal phase support, wherein we do progesterone concentrations, and then if we find it our cutoff is below 7. If we find it below 7, we do add additional progesterone. However, that is still under study, and we are trying to find out whether it's really working or not. And we have found pregnancies, to be honest, even with a progesterone of less than 3. So we are still trying to study it, but it is getting a lot of attention and seems to be a good practice. Because the numbers that we see in the studies are about 30%, wherein the progesterone levels on the day of transfer might be less, and we need to add additional progesterone to rescue the cycle. And that is why for studies, for people who can't do the monitoring, or it is not easy to do the monitoring, a lot of studies are now advocating a combined strategy rather than using a monotherapy of progesterone. Now, when to transfer the blastocyst according to the day of progesterone is again something which we have to understand, that for a blastocyst, people tried to transfer from day 5 to day 7 of progesterone, and they found comparative results. They didn't find any significant differences, which also reiterates that the window of implantation may span over 2 days. So there have been studies, and that's how, depending on the clinical evidence that is available till date, the valid evidence that is available, we are transferring embryo. The current practice, which is followed by all of us, is that we do the transfer on the P+1 day. So whatever is the embryonic stage, for example, if we are doing a day 3 embryo, we are transferring after 3 days of progesterone. And for a blastocyst, we are transferring after 5 days of progesterone. So this is what is the figure that is showing that we start the day of, once the endometrium is ready, we start the progesterone, 5 days of endometrium, and 6th day we do the transfer. So this is the current practice that we are following. And if you look at the corresponding fresh ET cycle, the day 1 of progesterone corresponds to the oocyte retrieval day, and then so on. And by the day the blastocyst is formed, we are on the 6th day of progesterone. So in a FET cycle for HRT, 5 days of progesterone exposure and 6th day transfer. That is what we are doing. So to summarize about HRT, it's the priming can with oral or transdermal routes have similar efficacy. Optimal duration is 10 to 36 days. Although pituitary suppression is suggested by some, clinical pregnancy rates have been similar. And the timing of FET is clearly important, because whether we can identify women's precise window of implantation or not is yet to be established. So it's really important that when we decide to transfer. So when we talk about HRT, everything is very good, right? The patient is happy, the doctor is happy. It is so flexible. We can do the transfer whenever we want. Patient just takes a tablet. No much of a monitoring is required. In fact, many of us don't even do any blood tests or progesterone or anything during the whole cycle, and we are getting good results. Then why are we so worried? Why are we so concerned about changing our protocols and moving to different kind of protocols? That is because of the adverse obstetrical outcomes that have been demonstrated with HRT. Clearly, because of the absence of corpus luteum, serum relaxin and certain vascular factors have been lacking, and that's why the hypertensive disorders in pregnancy have significantly increased, especially in HRT cycles. Not only that, postpartum hemorrhage and cesarean deliveries have also significantly improved, have been increased. So is it time to go natural? We have to think about it, that should we go natural, because corpus luteum has a lot of other benefits apart from just the estrogen and progesterone that we are providing in a HRT. And now, like I have highlighted, that because of the relaxin and other vasoactive substances, the placentation is better and rate of preeclampsia is lesser. So what happens in a natural cycle? We all know this. I have said this before also. During the follicular growth, there are follicular change, proliferative changes. After ovulation, secretory changes leading to a receptive endometrium. So how do we do a true natural cycle? I think all of us want to understand this, that how do we do a natural cycle in our practice, because it seems a little difficult. So what we do is, firstly, this is preferred in a patient who has regular menstrual cycles, who is ovulating on her own. So to schedule this, ovulation has to be precisely pinpointed, and that's how we can decide when to transfer. What we do is we call the patient on day 2 or 3 of her menses. We rule out whether there is any corpus luteum or any cyst, also see whether the endometrium has been shed completely. Now, in a woman who has regular cycles, whatever day of her cycle length is, 2 days prior to the expected ovulation, we call her back. So 28-day cycle, we can call her on 11th or 12th day. 26-day cycle, we can call her a little earlier, maybe 8th or 9th day. And what we do on that day is we do a transvaginal monitoring. If the follicle is more 16 mm or more, then we order a serum E2, LH, and progesterone levels. And depending on how the reports are, we call her either on alternate days or daily, so that we can precisely document when the ovulation has happened and when to do the FET. Now, to understand this better, let us go back to basics. I'll just take a minute to revise what we already know. So we know that the initial follicular phase, the estradiol levels rise and the endometrium starts proliferating, getting ready for the secretory changes. So now look at the cycle. If it's a 28-day cycle, we have called her somewhere around 11th day. What happens when she comes on 11th or 12th day? The estradiol levels are high. A dominant follicle secretes about 100 to 200 picograms per ml. So that is what we will be seeing on her blood tests. The LH and progesterone, the green and black lines are still at the baseline, so they have not increased. So here's where if we find that the estradiol levels have crossed 100 and the dominant follicle is 16, 17 or 18, now we know that any time after this, the LH surge can happen and the ovulation will happen in the next 24 to 36, about 56 hours also some papers say, after the LH surge. So what we are going to do is that if we find this picture, we are going to either call her or we can ask her to do the test at her own home, nearby lab, and come to us after 3 days also directly. We want to see in the next 2 days naturally how the LH and progesterone are rising and its relation with the estradiol, wherein it will be falling. Once we have seen that, what happens is gradually the LH starts rising. So here the LH surge starts. And if on this day we look at her LH, it would look somewhere maybe double or 3 times of what her baseline LH would be. So if it was 4, it would look like somewhere around 10, 12, maybe 15. If we look at the next day report, it would be even more than 30 or 50, or I have seen reports, we have all seen reports more than 80 also. And next day, you will see that the LH has fallen and the progesterone has started rising now. So here the progesterone is rising. And that's where you will see on the 3rd day that the LH, which was 30, 50, has now again come down to 10 and 12, and the progesterone has become more than 1. That's when we know that the ovulation has happened, and that's how we start the progesterone. And then the window of implantation opens up about 3rd, 4th day of progesterone and might be there for 3 to 4 days. So this is variable. It might open a little late for some women who have longer cycles and a little earlier for some women who have shorter cycles. So this is a revision of what we do. Again, on day 2, 3, we do a baseline ultrasound. Maybe on day 9 or 10, depending on the cycle length, or 11, 12, we call her. If the follicle is nice 16, 17 mm, we get the tests done. And the LH surge is noted. Tests are repeated every day for the next 2 days. Now, what happens if there is no LH surge noted? If there is no LH surge, it is still baseline 4, 5, then we can call her after 2 days and repeat all the investigations. That is when we will normally see the LH surge. This is how a routine normal natural cycle looks like. And we start progesterone on the day ovulation is diagnosed, on the evening of that day, and then 5 days later we do the transfer. There are certain questions here that, when we do only LH, we might be noting either the rise of the LH surge or fall of the LH surge. So we always have to combine them with E2 or progesterone to find exactly what is happening. If we do that, we will beautifully find that, there is E2 rises, then LH rises, then the LH comes down, the E2 comes down, and progesterone starts rising. So it's a very, very, simple thing that we can do. But yes, it would involve cost, it would involve follow-ups, it would involve tricks for the blood tests. This is again the same thing which I tried to highlight, that after the LH surge, generally the progesterone starts and we start the luteal phase support. Now, again, starting a luteal phase support in a true natural cycle, there was a controversy whether we should do it or not. But we always feel that there are subtle luteal phase defects in infertility patients. And then since we are doing an embryo transfer, we don't want to take a chance. So what we do in natural cycle in our unit, we follow that we give them 200 milligrams of vaginal pessaries twice a day, or 12 hours apart, or we give vaginal progesterone gel once at bedtime. So for 5 days, and then 6th day we do a blastocyst transfer. We have now moved to a single blastocyst transfer for most of the patients, but if we are doing a day 3 transfer, 3 days of progesterone and 4th day transfer. However, there have been a lot of challenges with the cycles, and not only that the LH surge are variable in amplitude, duration in various individuals, monitoring is required. It is also that it can be, the flexibility of the clinician and the embryologist is gone for a toss. So, for example, if ovulation happens on Tuesday, the transfer will fall on Sunday, and the embryologist and the sister and everybody will start blasting us that, ma'am, what have you done? Why have you done this? You have called and calling all of them again and again on Sundays is a task. So considering all this, high cancellation rates also sometimes we do, and we find the progesterone levels are already 2. Patient has already ovulated. So cycle cancellation rates are high, it's invasive testing and flexibility is compromised. We can solve all these issues by modified natural cycle, and it is coming up in a big way because flexibility is an issue. So in a modified natural cycle, like we all know, we can give a HCG injection and induce ovulation. Now, and it has been proven beyond doubt that the HCG triggered cycles and true natural cycles have equal live birth rates. In fact, some studies have demonstrated better live birth rates in HCG cycle. This could be because of the precise embryo transfer timing, and maybe the exact moment of ovulation may not be found in a true natural cycle, and that's why the HCG triggered protocol are achieving better results. What we do is we can give a trigger anytime between 16 to 20 mm diameter, and then 36 hours later we start the progesterone and do the transfer as per the progesterone exposure days. However, there are two controversies in this. One is that people always say that if the LH surge has already started, then what happens? The ovulation already happens by the time we do the transfer. So for that, some people have suggested LH levels to be done. But it has been seen that even if the LH levels are 16 to 40 and we give a trigger, the outcomes remain the same. The second is now they have started studying whether we can give the trigger at smaller follicles also. And still it might be viable, because all we are trying to do in these cycles is to have a corpus luteum and have a better obstetric result. So what happens is if the follicle is growing even at a size of 13, 14 mm, if we have achieved the target endometrium and a good healthy triple line endometrium, then why to wait further? We can have a flexibility of giving the trigger whenever we want to in this range of follicular sizes, and plan the ET as per our convenience. And again, they have found that there is no difference in the pregnancy rates, which are clinically significant. So this is an additional opportunity for flexibility. And same thing has been reiterated in this study by Garcia Velasco, where he has said that there is a window of almost 7 days which can be utilized. And this is a good study if somebody wants to go through. Also, avoiding weekend transfers. So they have literally studied this, because the only downside of natural cycle was mainly we could not plan it well, and weekend transfers were falling, and this is how we can avoid weekend transfers. This is just a gist, wherein in HRT cycle it is 5 days and 6-day transfer. LH surge is 1 day plus compared to progesterone cycles, and HCG is another 1 day plus from the LH. So it is P plus 5, LH plus 6, and HCG plus 7. Now, there's one more concept which has coming up is natural proliferative phase FET, demonstrated in 2024. And this method capitalizes on the endometrial preparation stimulated by a growing follicle during follicular phase. What we do is, once the endometrial thickness is reached 7 mm and we do progesterone also, if it is less than 1.5, we just start exogenous progesterone and do a blastocyst transfer after 5 days of progesterone exposure. We don't look at the follicle because we have confirmed that it has not ruptured, even if it is small, it's yet reached only 12 or 13. We can do this also. And again, the pregnancy outcomes were comparable to a natural cycle FET. The basis of this is that the preservation of ovulation is still there, so that the protective effect of the corpus luteum against the obstetric complication is still there. And this has been reiterated in 2 or 3 studies now, and it has been proven, like, you do it like a HRT, but based on a natural estrogen. You just let the endometrium grow with the follicle, and without even seeing whether the follicle is big enough, you just start the progesterone, do the transfer whenever you want to do. Very effective, good protocol. Now, to summarize the conclusion, in conclusion, the use of innovative strategies like triggering at various follicular sizes and NPP protocol, it offers a good flexibility, avoids weekend procedures, and improves clinical workflow and patient convenience. Now, quickly a word about, I don't know, ma'am, whether I'm overshooting my time, but I'll quickly finish. Just few more slides left. Ovulation induction cycles are comparable with natural FET. The primary distinction here is that we are stimulating a follicular growth using ovulation induction agents, whether it can be aromatase, clomiphene, or gonadotropin, though personal choice preference is letrozole over clomiphene. And of course, gonadotropins can be added. This is majorly advantageous for anovulatory patients because it preserves the natural ovulation and functionality of the corpus luteum, and exogenous estrogen is not required. And especially in polycystic ovarian syndrome patients, it is found that it has a lower risk of hypertensive disorders in letrozole-induced cycle compared with artificial cycles. This has been now proven beyond doubt. Now, this is exactly like the same way that we do in natural cycle, except for here we give a letrozole either in 2.5 or 5 milligram, depending upon the BMI of the patient, for 5 days and monitor it just like we do for any other ovulation induction cycle, except that once the follicle reaches a dominant stage of 16 to 18, we need to monitor every day so that we can pinpoint the ovulation. This is just a picture which summarizes everything that I have said till now. It's a good slide. I found it very useful as a gist of everything. And this is what I wanted to say. So to conclude, in ovulatory patients, natural cycles should be prioritized given the association with fewer obstetric complications. Use of an HCG trigger in these cycles may help better determine the timing of embryo transfer while requiring less luteal phase support, because HCG itself also acts as a luteal phase support in these cycles. For anovulatory patients, ovulation induction agents can be used to simulate a natural cycle. When artificial cycles are necessary, when we can't use anything else, like for patients of low reserve, we have to use artificial cycles. We can't make a egg. Individualized progesterone supplementation should be considered. We should look at how much her progesterone is on the day of transfer and then rescue the cycle if it is less. If intensified luteal phase support monitoring is not feasible, if we are not able to do the progesterone levels, then it is better to use a combination route of progesterone. Now, given the clear association between artificial cycles and higher rate of obstetric complications, we should counsel the patients about the choice of method for endometrial preparation, because sometimes patients will say, "Bar aana padega, tests karna padega, why not better go for HRT?" So we need to counsel this because now the evidence is very clear. We should tell them that the monitoring will be less now, but the pregnancy will be uneventful. All the complications will be lesser than what it would be with HRT cycles, especially in advanced stage and obese patients. And so that is one counseling which is important. Also, the number of medications that she will have to take will be much lesser than in a HRT cycle, because there will be only a vaginal progesterone and a folic acid that we give in a natural cycle. So the final word is natural cycle may reduce obstetric complications and should be prioritized. Flexibility is promising, and recent individualized LPS has been researched extensively and now is becoming a standard practice. So thank you so much. Thank you for having me, Jyoti ma'am. Are we taking the questions now, or?
We'll take the comments from our chairpersons. We have Dr. Renu Chugh. I can see her. If Dr. Renu, please, your comments. And if Dr. Deepika and Dr. Manju Khurana are there, we'll take their comments as well. It was a brilliant presentation, Dr. Tejashree. Brilliant.
Thank
Wonderful.
you. Thank you so much.
Okay. Good evening, everyone. Sorry for being late. I couldn't introduce, but certainly I could listen to the whole lecture. It was fantastic. Very, very valid explanation. And in detail, you told us about everything. And, just to, somebody else is there. Can you please mute? Yes. Thank you, doctor. So in nutshell, I would like to say that the natural cycle is the best, no doubt. But seeing the convenience, we can switch over to the modified natural cycle. But in fewer cases, as we are doing batch IVF, many of us, because of lack of availability of embryologists, we can still sometimes we have to do HRT cycles. And in many indications also, we have to switch over to HRT cycles. But that should be the last resort, I would say, keeping in view the obstetric complications and pregnancy outcomes. So we should avoid HRT, go for modified natural or natural cycle and stimulated cycle in an ovulatory woman. So doctor, thanks a lot for everything.
Thank you, ma'am.
For excellent presentation. Excellent. As
Thank
we are
you.
running short of time, so I would not waste any more time. Any questions from the audience, they are welcome.
I think Dr. Manju and Dr. Deepika, I can't find. But we'll take only two questions here. Dr. Sonal has asked role of HCG injection in HRT. If briefly you can comment on that.
I would like to in fact highlight here that there is absolutely no role of HCG in HRT cycle, because there is no corpus luteum. It is not going to help us in any way. HCG acts on the corpus luteum, and that's why probably it acts as a luteal phase support in natural and modified natural cycles also. But in a HRT cycle, there is absolutely no role in of giving HCG.
Right. And the second question, should we do progesterone levels on day of starting and again on day of posting?
So day of starting, initially there was, it was suggested that we should be doing progesterone levels on the day of, before starting the progesterone levels. But that the more important thing to find out here is whether there is a natural rise of progesterone already happening. Are we dealing with a escape ovulation, or are we dealing with, anything natural that is produced in the body? So that is the purpose of doing a progesterone before starting the progesterone as a luteal phase support or as a endometrial preparation. But of course, if there is a suspicion, if you think that you are seeing a follicle on the ultrasound, then only there is a role. Otherwise, for routine cycles, we don't do a progesterone before starting or we are doing an ERA cycle. We want to know the exact timing of starting progesterone. That's when we do a progesterone before starting. But yeah, on the day of transfer, we like to do now, even as a part of study, and we do intervene if it is low.
Thank you so much. Thank you, Dr. Tejashree.
Thank you, ma'am. Thank you for having me. Really a pleasure. Thank you for this honor. Thank you.
Hello, doctor. Can I ask you one thing, if you permit? As you said, the lowest limit for FET progesterone levels is 8. Less than 8, we should not transfer. So is there any higher limit also?
So studies had come up with saying that, the higher levels are also harmful at a point, but there is no consensus on that level yet. And that is why we are not moving to a combined progesterone protocols as yet. We haven't moved to a protocol wherein we are giving daily injections of progesterone because that might go to very high levels of progesterone and might be harmful, yet to be proven, but might be harmful. Dr. Sachin sir is here, and I'm sure he will guide us more about it. Yeah, so maybe that is the reason we haven't yet moved to addition of injectable progesterone every day till now, because sometimes the levels go really up and that could be harmful.
Yeah,
So we
that's
don't know what levels.
Yeah, because
Actually,
we see the prescriptions, many people, they are writing vaginal, oral, and injectable, all the three together. So
Right.
will it harm or it will not harm? Just I want to ask that. Is
I
there
think
any?
Sachin wants to
wanting to
add.
say something.
Dr. Sachin, yes, sir.
Yes.
can I just put in firstly, that was an excellent overview of the FET protocol, Dr. Stotri. Kudos to you. Very nice it was indeed. Regarding this progesterone level, there is a very mixed kind of studies which have been published about a higher progesterone level could be harming the implantation rate. But all those studies have a fallacy because those studies were produced with vaginal progesterone administration. Since the time Kate Devin published a study of giving intramuscular progesterone, the scenarios have changed. So now we realize that we need a vaginal progesterone to maintain a good endometrial progesterone because that is receptive endometrium and better implantation. But for maintenance of pregnancy, we require a high progesterone level. How much high it goes doesn't make a difference. The reason behind this is when you have a high progesterone level, the progesterone in the blood is bound to corticotropin binding globulin, also bound to albumin, and some amount is free. So if your progesterone in the blood is high, most of the corticotropin binding globulin gets occupied. So at the endometrial level, there is amount of free progesterone goes very high because the corticotropin binding globulin in the endometrium comes down and the free progesterone goes up. And that is probably responsible for an better continuation of pregnancy, better ongoing pregnancy rates, and lesser miscarriages. That's why there is a nice article which has been recently published by Kate Devin that the standard of care in optimizing ongoing pregnancy rates in FET cycle with HRT protocol is intramuscular progesterone. That has been recently published now. So that's the role of progesterone levels. The higher doesn't make that much of a difference. Rather, it protects from a miscarriage.
Okay, that means we can give at least two routes, vaginal and intramuscular.
Absolutely, absolutely. So it is our duty, especially in a FET cycle, to maintain a good amount of progesterone in a serum progesterone level. Very essential.
Thank you, doctor.
Thank you so much. Thank you, sir. And thank you, Tejashree. Now, moving on to our second session, it would be, I would invite chairpersons for this session, Dr. Manisha Mehta, Dr. Parul Khanna, and Dr. Nishu Singla. So they would be chairing this very wonderful talk by our guest speaker, none other than Dr. Sachin Kulkarni. Dr. Sachin Kulkarni, sir, is a consultant at Sunanda IVF Kolhapur, and he is head of Department Fertility and Reproductive Medicine, Jahangir Hospital, Pune. He is a teacher at Reproductive Medicine course in Dubai, and he is consultant New Leaf Fertility Center, Addis Ababa. So he regularly conducts fellowship programs in IVF and reproductive medicine. And it is our privilege to have you on this platform, sir, today. And sir would be talking on optimizing the ET. So how do we optimize once we have a good endometrium? So now it is in our hands for the pregnancy to occur. For that, we have to be very as perfect as sir. And let's see how he does it.
Well, thank you so much. Can I share my screen a bit?
Yes, sir. Now, please, it's you can share it from your side.
Okay. Is my screen visible now for everyone?
Right, sir.
So thank you so much, all of you, for extending this opportunity to me for sharing these thoughts on embryo transfer. And this is, though embryo transfer is considered to be one of the simplest of the procedures, I think it is one of those very delicate procedures, needs all the finesse and all the accuracy to perform. And this is one of those steps of IVF procedure which has not changed after the birth of the first baby as well. And not much has been changed. Secondly, I think this is one step where the science is making hope to achieve a pregnancy. So it has to be given the topmost importance when we do an embryo transfer, so that a conducive atmosphere is created. All the money the client has spent, all the efforts taken by you in thinking and brainstorming your ovulation induction protocols, all your OPU skills, the laboratory skills, all your machinery which has been into the best of its ability to make such good embryos, and they're going to go in, and any problem at this step can hamper all the efforts taken in the past. So this is one of those, though looks simple, it's a very delicate and high finesse is definitely required when we do an embryo transfer. If not done well, can spoil the success independent of all other factors. So I feel a mock ET is a must, an absolutely must. Just a moment, give me one moment, just one moment. Yeah, sorry. Yeah, mock ET is a must. And we must have, before doing an embryo transfer, a pre-embryo transfer discussion should be done with the client regarding the kind of embryos you're going to transfer, what kind of method of embryo transfer, and what is the post-embryo transfer care. And obviously, we will have a cross-check on the adequacy of bladder beforehand, before we take up the client to start off the procedure of embryo transfer. After that, I think mock ET is something which is absolutely a must procedure. So every team has a very specific preferences of executing embryo transfer. It is highly dependent on the clinicians and the embryologist preferences. I have seen embryologists also pushing the embryo, some which is afterload technique, sometimes it's preload technique. Every clinician has his own way of choosing the catheter, etc. A physician factor definitely plays a role in the success. More experience the physician, more finesse and accuracy the physician has, more calm and cooler the person is, definitely the chance of pregnancy is better. And many studies have reported physician-specific success rates when it comes to embryo transfer. So today we'll be discussing about the anatomical position. We'll talk a bit about single embryo, double embryo, what is a difficult embryo transfer. We'll also think about, suppose we have to re-vitrify the embryos. What is preload, afterload? What is an ideal embryo transfer? And embryo transfer with TBS guidance. And these are the agenda which I would like to cover in my talk. There are two phases of embryo transfer. One is cervical canal negotiation, and second is atraumatic deposition in the uterine cavity. Both are very important. So this is a very interesting paper. It's a Paris paper talking about the anatomical causes of difficult embryo transfer during IVF. And in this particular paper, they looked at about 306 IVF cycles. This is an observational study. Actually, this is a study which was done in 2010 on 50 difficult transfers. And they identified 5 anatomical characters, and then they continued the protocol further. In 2016, they came out with this particular data. And they looked at the position of the uterus, they looked at tortuosity of the cervical canal, and these are the exact things which we need to keep in mind when we are doing an embryo transfer. Cervical crypts, presence of the cervical crypts, what are the internal os contractions and anomalous cervix. And depending upon these factors, they looked into what is the frequency of ease of transfer and difficult transfer. How many are easy transfers and how many are difficult transfers. And this is one diagram I would say we should put it on the mock ET form. I'm going to post my mock ET form here. So this is to be done. So look at the external loss, some median at the external loss and internal loss. That could be a variable position, and that's the one which is going to decide about the tortuosity of the cervical canal. And then what is the position of the sagittal plane of the uterine cavity, and how much is the angulation of 45 degrees, 45 to 90 or beyond 90 in antevertebral retrovertebral position. So we have to know the central longitudinal axis of the uterus as the central axis, and degree of uterocervical angle measured in 3 anterior and 3 posterior positions, and you can put this on paper. So this is my mock ET form, which I use in my practice. So after the pickup and everything, most of the cycles are resolved. When the client comes for the next visit, this is a type of form we follow. And we look at every detail of, what is our negotiation plan, like up and right, up and left, direct down, up, then down, etc. Smaller things which have been mentioned there. Is it going to be smooth with a cuspospeculum? Is the vagina deep? Sometimes obese women have a deep vagina and lateral vagina walls are hanging. and cuspo speculum goes inadequate. I'm going to suggest you what we do there, and will anesthesia be required? Then we put it a plot on this particular diagram, how the catheter is going to grow. And this is the form which we maintain for all our mock embryo transfer. And that's a must procedure in our IVF. And internal, external loss and a virtual middle reference point. Is it aligned or tortuous? Now look at the diagram on the right, where the canal is going down and then going anteverted. So this can happen, especially patients who are having posterior wall adenomyosis, endometriosis, deep infiltrative endometriosis, etc., or previous cesarean section, tortuosity of the cervical canal, or very acute changes at the uterine and cervical angles could be obvious, and those need to be taken care in the mock ET itself, and a proper plan has to be formed so that the whole transfer goes very easy for all of us. Abdominal USG probe position is very, very important. Like many times when I'm sitting in front of the client and I put my cuspo speculum, I look at two things: how my assistant is holding the abdominal probe so that I'm getting a correct sagittal plane. Is she holding an abdominal probe in an angulated fashion or a straight fashion, and which side is the angulation? And is my cervix also looking in the opposite direction? And that way I know in which direction I have to negotiate my catheter. And this is few examples I'm giving you. Look at the diagram A, whether the cervix is looking down and it is looking on the left side of the operator. So the uterus is going to be up and on the right side. While the B diagram, the cervix is looking up and centrally. So the uterus could be going down and retroverted uterus. So vaginal, the value of the vaginal cervical position is very, very important to understand how your catheter is going to travel, and obviously the ultrasound feature and the sagittal plane of the whole endometrial canal and as a cervical canal alignment is going to tell you which catheter you would choose. Are you going to be choosing something like a Cook the curved catheters like Cook and Labotec, or would you choose something like a Wallace catheter? What about single embryo transfer and double embryo transfers? Now, whole world is definitely moving towards single embryo transfer. As far as women beyond the age of 35, 36 are concerned, we are doing PGT very often. Obviously, single euploid embryo transfer has come a big way there. Now, should we be still doing double embryo transfers for somebody who is less than 35 years and supposed to, so we have a good embryo and a low quality embryo? Should we be mixing that embryo and transferring it? So this is a nice paper published which talks about impact of transferring poor quality embryo along with a good quality embryo on pregnancy outcomes of IVF and ICSI. And just for the sake of it, there's no point transferring two embryos, and we cannot trade off between multiple pregnancies and a high pregnancy rate. Like if you put two embryos, obviously chance of multiple pregnancies is high, but again, you will get a high pregnancy rate also. But if you put single embryo, pregnancy rate may drop down, but obviously multiple pregnancy won't be there. And that trade-off is very difficult to decide. So best is to have a very shared decision making between clients, and you will be surprised. And I'm sure you're coming across these women where the family says, well, put two embryos, we would love twins, in spite of telling our heart out that twins could be risky and twins can have prematurity and issues like that. They still want you to put two embryos. And otherwise, a single embryo transfer, single good morphology blastocyst is very good for somebody who's less than 35 years. So whom we electively will advise a single embryo transfer? When you have an euploid embryo, obviously it's always a single embryo transfer. If it is a first embryo transfer, patient has a smaller uterine size because it's a unicornuate uterus, or it's a scarred uterus, previously myomectomy or adenomyomas have been removed. Patient already has history of a twin pregnancy, abortion, or they are having some systemic diseases which may not allow us a twin pregnancy, and that's why like it could be an SLE or something which is sarcoidosis or some kind of a connective tissue disorders where twin pregnancies could spoil the whole game. Rather, the patient is also having hypertension. Again, having a twin pregnancy could be more disastrous. So in such scenario, we should convince our client to go for a single embryo transfer. Double embryo transfer, well, patients who are having a recurrent implantation failure, multiple IVF failures, older age patients who are medically fit, to improve the chances, especially if they're not going to go for a PGTA, then a two blast. But with the advent of PGTA, the situation has come down drastically. There is always a good embryo and endometrial crosstalk, and that is what decides the implantation rate. So you cannot put a good and a poor quality together. If you do that, there is a decreased implantation rate, and the endometrial crosstalk is different, and with the definitely low interleukin levels. And this is a nice paper by Downer et al. They did fresh embryo transfer with one good and one poor, and and they say there is a reduced pregnancy rate. So we'll have to talk this out to our client, have a shared decision making, say this is a good embryo and this is a relatively low grade embryo. I would prefer transferring a good embryo rather than transferring both together. So let's understand what is a difficult embryo transfer. So the UK National Survey 2021, they looked at the difficult embryo transfers and they classified them according to the type of management the clinician adopted to. And they said that if you use a stylet or there is a change to another catheter, like a change from Wallace to Cook or to Labatec, use of a tenaculum and pull on the cervix, you have to do, it's not going in one go and you have to go for 2 or 3 goes at it. You have to call for help of a senior person to help you out with an embryo transfer. You could not do it up and you have to freeze the embryo and transfer, take a transfer for another day, or you really had to use cervical dilators and all that factors. Any one of these factors says that this is a difficult embryo transfer. So a simple transfer would be a simple custom speculum, one go, smooth transfer, like a butter you're going inside, like a knife in butter. So again, when you do embryo transfer, and this is very important, I feel, why we do an ultrasound guided embryo transfers. What is an optimum transfer? Commonly, if the cervico-uterine angle has angulated, beyond 45 degrees, and in spite of a bladder filling, the bladder may not be adequate, or it is an angulated. And if you are not negotiated the internal loss, you are just at the internal loss, and we push the inner catheter, sometimes the inner catheter can go subendometrially. Look at the diagram on the right, the gray arrow goes subendometrially. And when we push it up, push this, the embryo goes up and comes back. It reverses back, or it just in the subendometrial space, and obviously this pregnancy is not going to be there. So this is something which needs to be mastered, that you are definitely there in the central cavity and put the embryo at least a centimeter below the fundus, and the chances are better. Then you should not be going too much at the tubo-ostial region, or you should not push it very hard so that it bounces up from your catheter toward the tubo-ostia. And sometimes, rarely, an ectopic pregnancy, even after a blastocyst transfer, could be seen because of this particular thing which may take place. If difficulty, what to do? You just remove the catheter, put the embryo back to culture. Now, this is one step to be remembered. This culture dish under oil should always be kept ready at the your laminar flow, so that if you have to remove the catheter and put the embryo back, it should go under oil immediately, so that the sanctity of the embryo is maintained to its best. Once you remove the catheter, do a repeat thorough transvaginal scan. You can change the speculum size, you can change the amount of bladder filling, reduce or increase it. You again identify the new catheter pathway and again take a new catheter and negotiate it. If you have to do all this, it is called a simple difficult transfer, because at the end of encountering a difficulty, you are still able to manage an embryo transfer in the second go. But even if the embryo transfer is not possible in the second go, then that is called a persistent difficult embryo transfer. And this is one typical scenario which we come across a previous cesarean section. It's just a diagrammatic representation that the cervix is anteverted and it is going all the way up. There is a bladder and cervical adhesions are there. Cervix is also a bit elongated. Then there is a isthmocele at the place at cesarean scar, and the whole of the uterus is retroverted. The body of the uterus is retroverted. So commonly the catheter goes very easily and tries to go more in the isthmocele rather than negotiating posteriorly. Neither do you have fixed cannulas or fixed angle catheters which can negotiate that posterior portion. Many times in my case, if I've encountered this and I'm not able to pass, the catheter is easily going to the isthmocele but not going back down. Obviously you keep a low bladder, everything you do, but it's still not going. Then I have withdrawn it, stop the procedure, or at MOPT itself we identify. Nowadays we got a little more conscious about it, that previous cesarean, this is one factor we look into. And we take up the patient for a hysteroscopy, and what I have marked with red, that curve red, that is a hump, we resect it with hysteroscope so that our catheter can easily go into the uterine cavity easily. And this has really, this particular resection has really helped me do easy embryo transfers in subsequent IVF transfers. Or you can make use of also this kind of a catheter. This is an Indian make, which I'm showing on the right side. The metal catheter, what you're able to see. I think it's available for about 6,000 bucks or 12,000 rupees by a company here. the curve, the red color portion of in the circle, what you see, is actually a kind of a spring. So it flexes, while the lower part of the catheter is a stiff part. And there is a nice knob at the top, which makes it traumatic. And they have their own inner catheter separately supplied. So your Cook and wireless inner catheter don't go through that. So in a great difficulty, if I'm having, then I would use this particular catheter. So the flexi part is, though it is flexible, it is made up of metal, so you can easily negotiate the difficulty, and then you can pass the catheter usage. So I think this is one instrument which should be available for us to do difficult embryo transfers in our clinics. What about revitrification of embryo? Sometimes you're just not able to transfer, and there could be bleeding, or there could be fluid in cavity at the last moment, or there could be an embryo which is retained and it just comes back and you want to revitrify it. Yes, you can do revitrification of embryo. Let's say what literature talks about it. And this is the efficacy of transfer of twice frozen thawed embryos with vitrification method. This is a public paper published, and it talks about once frozen and twice frozen. Look at the implantation rate. The implantation rate was once frozen 19%, and this was 25% with twice frozen, 11 out of 44. So it's not much significant. So even if you have to twice freeze thaw, the vitrification and thaw procedure is so robust and so good. And if your embryological laboratory standards are very well maintained, KPIs are good, you can go ahead and revitrify. I'm sure a success will be not altered at all. What about the retained embryos? Do retained embryos in the transfer catheter and immediate retransfer? The one policy is to revitrify. Another policy is to immediate retransfer. And will it then affect the implantation clinical pregnancy? And this can happen. You may one of the embryos may just come back, and the embryologist said, "Well, it is not clear. Would you like to retransfer?" You said, "Yes, I would like to retransfer." But there is a very fair evidence that the secondary outcome of an RCT and 9 cohort studies that retained embryos in the transfer catheter and immediate retransfer do not affect implantation and clinical pregnancy rate. And I think this is something which should be told to the patient before even we do an embryo transfer, that rarely this is possible. You can always quote in a year, one of a times I will be seeing, in a 2 year I've seen, or I've never seen, only literature has reported this. Whatever is your practical experience, share with the patient so that you can take a judicious call later. What about cervical dilatation? After encountering difficulty, it may happen. Like you are doing a mock AT, you're not able to negotiate, and you take a decision to do cervical dilatation. So obviously you'll post her for an operation theater, for some anesthesia, and do cervical dilatation. Or first ET was difficult, and then that's why you're planning a cervical dilatation and doing the second ET. So what should be the duration between cervical dilatation and the next embryo transfer? So or you could have done a hysteroscopy later also with cervical dilatation to see the canal, etc., before you do a second embryo transfer or after a mock embryo transfer. More time you take, like longer time after dilatation, better is the pregnancy rate. You can dilate to Hagar 6 to 9.5 or soft laminaria 10, that can be used. But longer time you take, the pregnancy rates are better. That's what the literature says. That also the Hagar dilator and the pregnancy rate. You should not dilate only till 6, 6.5. Better to go to dilatation to 7 to 9 ideal, so that the pregnancy rate is better when you transfer at the second time. What about preload and afterloading catheter? I think most of us are doing afterloading catheter, where we put the Wallace SureView with the inserter inside. The inserter is removed, and then the embryologist loads the embryos, hands over to you. You remove the insert and then put this catheter inside and then transfer it. Preload is, I think I used to practice it way back, 20 years back, I would say, when only CCD France catheters were available. But ever since these double lumen catheters are available to us, the outer and inner, I think we have all shifted to afterload, but it is a personal preference. Afterload, I feel, is much better. This is again, this is a study of about 8,000 transfers, preload or afterload. This is the clinical pregnancy rate. The odds ratio did not make much of a difference. The clinical pregnancy rate was the same. But the difficulties of doing embryo transfer were 9% up with afterloading technique, while 26% with preloading technique. And imagine you're using a preloaded embryo transfer catheter. You're trying to negotiate. You experience a difficulty. Your embryos are sitting in the catheter. So obviously your problems are going to be higher. But in afterload, even if you encounter difficulty, the embryo is nicely resting in the laminar flow or an incubator, and that is much protective, especially in such scenarios. What about uterine contractions? We need to take care of uterine contractions. I'm not in a great favor of using atosiban or any piroxicam or any of those things in my embryo transfer practice because I believe what is peristaltic movement is more of that junctional zone peristalsis that should be quiet. And junctional zone is not something which responds to atosiban or piroxicam. It responds to higher amount of progesterone. So whenever we are doing embryo transfers, we look at the progesterone levels. The progesterone level should be beyond 10 nanogram. And also we have made a habit of giving an intramuscular progesterone in oil injections about 4 to 6 hours prior to embryo transfer. So typically in our hospital, the client lines up in the morning, the blood is collected for progesterone level, and an intramuscular dose of progesterone is given to them. Then they just take their breakfast, everything. Once the progesterone report comes after 2 hours, if the report is normal, then we tell the client, well, your report is normal, and we're going to thaw the embryo. Then we thaw the embryo. The thawed your leaf is shown to the couple that we have thawed their right correct embryo, etc. Then the thawing period for 2 to 4 hours, and all the embryo transfers are done afternoon. So uterine contraction do make a difference, but I prefer giving progesterone. And this is by a Robert Casper study, wherein they looked on a previous day at the uterine contraction. If there are more than 3 waves in 10 minutes, they recommended intramuscular progesterone to be given and then transfer the next day. But since it is cumbersome for every client to come on the previous day, I prefer doing it in the morning hours and then transfer in the evening time for patients. Embryo loading time and transfer time, there's a gradual decrease in success as the time increases, especially if it goes beyond 2 minutes, the results are poor. There is no benefit of something like delayed withdrawal, no need to rotate, no prolonged bed rest. The prolonged bed rest after embryo transfer has harmed the success rate. That's what the evidence is saying. So there's no need to do all these hanky-panky things. You just gently have to go in and come out as if you were never there. And that smoothness is what is necessary to do a good embryo transfer. Now, this is I'm just showing you how we manage obese patients who have deep vaginas. And when you put a cusco speculum, your lateral vaginal walls fall in to the as the cusco speculum opens and the cervix is obscured. So I put this sterile condom, I feed it on the cusco speculum, cut the tip of it, you can see on the right hand side, and then I put the cusco speculum inside. With this, then you open it up, your condom is not allowing the lateral hanging walls of the vagina to fall in. You can have a clear view of the cervix, and embryo transfer catheter can pass in very easily. What about transvaginal scan-guided embryo transfers? So it can be done, but it's a little cumbersome procedure. The first thing is to put a outer catheter by the external loss, guiding it to the internal loss on abdominal scan. Then you put an TVS probe, wait till the patient is comfortable and you're able to see the sagittal plane. And then the embryologist will load the internal catheter, deposit, and then you deposit in the middle of the cavity. I feel this is pretty difficult. I have rarely done this. I don't know how many hands will be required to do it because you're going to require your left hand. You're going to require somebody holding the probe, and embryologist coming in, he's handing it on your right hand, and then you putting in the catheter. So multiple hands and multiple movements. It's something very difficult, but needs a fitness to be achieved. I've not achieved it yet. A very difficult situation, I would do something like this. So what's an ideal embryo transfer then? Which techniques make a difference? A USG guidance must observe a double drop, one drop of the embryo, and second is the air which you push behind that. Removal of the cervical mucus, yes, makes a difference, but don't remove it that vigorously that you are causing contractions of the uterus. Be using a gentle media. You can take long swab stick, dip it in the media, culture media, and move it on the cervical mucus from inner to outer and remove it, or you can use a syringe to suck it out. Warm normal saline. Many times if I see a lot of mucus, I just put a warm normal saline, swab under cervix, wait for a while, the mucus dissolves and then it goes very easy. You can even use a normal media there, swab full of media can be put and the mucus can dissolve. External catheter should be at or before internal loss. If the external catheter is beyond 1 centimeter of the internal loss, your pregnancy rate drop down. And you should transfer your embryo 1 to 2 centimeters or the middle of the cavity is the right thing to know. Well, thank you so much, all of you, for a patient listening. I'll be open for any questions or any queries there. Thank you very much for this opportunity again.
Thank you, sir. It was a very enlightening and enriching lecture. And you explained each and everything that we face day to day in our clinical practice. And now may I request Dr. Parul Khanna, the chairperson, if she want to comment.
Thank you, ma'am. Thank you, sir. That was indeed a wonderful lecture, a complete lecture, as ma'am has already said. And you have completed, I think, almost all the difficulties which feel we face in the practice during embryo transfers. As you have rightly said, I have also faced a problem of retained embryos also, and that too in the same patient. In the next transfer also, I when we were prepared that we have already had an experience of retained embryos, we still in the second attempt had retained embryos in the same patient, but we immediately decided to transfer both the embryos, and we had pregnancy. Both the times we had pregnancy, first time but it aborted, but second time the patient had twins. So that is one of my experiences. And that rightly what the other problem which you had mentioned, that the hinge during the embryo transfer, so that hinge was faced by me also. But once, even after bypassing the hinge, it went into the posterior wall of the endometrium, and we had an ectopic pregnancy wherein the embryo trans got implanted in the myometrium, posterior myometrium. So that is one of the rarest sort of ectopic pregnancy which I had experienced in my practice. So that managing that hinge in the hysteroscopy is one thing which you have mentioned, and it would be very helpful for me and others as well. So once again, thank you so much, sir.
Thank you, Sona. Thank you.
Thank you, Dr. Parul. Sir, there are a few questions in the chat box that
Yeah.
may I proceed with the question, sir? Sir, there is one question that if we take out the embryo in embryo glue and we are ready to transfer, if and somehow we are not able to go ahead for the transfer procedure because of difficult embryo transfer, can we refreeze them?
Yeah, very much, very much. You can revitrify. So what we do is we always keep a culture plate or one of the wells with oil overlay. Always keep it ready in the incubator. If you have to, we just withdraw it and hand it over to the embryologist immediately. So he can immediately put it under the oil in the media and put it back to the incubator. And then after some time, he'll revitrify the embryo. No doubt about it. We can revitrify.
And sir, there is one question. When you do mock ET in the same cycle or in the previous cycle, on which day and how you plan?
I don't think in a particular day is important. I always have one period of rest cycle. In my practice, once I do OPU, most of my freeze-all cycles. So when they get periods and they visit me, we have one detailed discussion about what embryos we have, what we're going to plan. Is there any reason she can fail in spite of transferring embryos, etc. Around that time, we place one appointment for them for a mock ET, and then we conduct a mock ET at that point.
Okay, okay. Thank you, sir. And sir, there is one more question that can we use Alice with a gentle traction and we can negotiate the outer and then, or
Yes, you
yeah.
can, because that is the way to negotiate an acute angles at the cervix which are not adequately corrected by the full bladder. And many times, how the bladder and the uterus relationship takes a decision on those things. So you may have some patients with a partially full bladder, a nice horizontal uterus will be seen, while some patients in front of the full bladder, certain angles are mentioned, or the bladder is not able to go all the way to the fundus. These are anatomical variations which we commonly see. In a scenario like that, there's nothing wrong in pulling the cervix. Sometimes a previous LSTS patient, the cervix could be high up in the vagina, very difficult to reach all the way anteriorly. You may have to pull it down by using an Alice traction.
Okay, thank you, sir. Thanks a lot. And
Sir, one more question I have. Do you have any experience in transmyometrial transfers?
I was expecting this. Looking at that, I don't have hair. I think everybody would ask a question like this to an old man. But believe me, I have no experience of this. But I have seen one. I've seen Dr. Anil Guri doing one in London, and I had once ordered a transmammary catheter, but long back, and I don't think I ever used it. But I wouldn't dare it. I wouldn't do that. Rather, I do hysteroscopy and make the canals improve, and then do a transcervical. I don't see a reason nowadays of doing a transmyometry. In what scenarios one would do that? Probably some more people can opine on this, but I'm not. I have no experience much on this.
And sir, another case wherein once because of adenomyosis, the uterus was so bulky and the canal was so elongated that the outer catheter, like even after Cuscos and all, the entire, I felt that the catheter was appearing too short for the transfer. So what should be done in such cases?
Yeah, I think these are very, very peculiar situations. I would give a general anesthesia for this particular case so that I can put nice vaginal retractors I can use so that I can make some space in the vagina. And when I put the catheter inside, I can put my finger a bit in the vagina and, uh, then push the catheter inside so that it goes all the way to the negotiate the cervical canal, goes into the internal os, and then I can push it further. Because such deep things require you to do some manipulation in the outer third of the vagina, which is not possible with viscose there. So I think we'll have to just educate the client and tell them how we're going to do it so as to ease. So these are the reasons why mock embryo transfer has a huge value in our IVF practice today.
And sir, there is one more question. How many hours you keep the embryo post thawing, like day 3 and day 5, 2 hours, 4 hours, 6 hours? So how you proceed like with
Yeah,
the
actually, it varies. Goes for it's more of a question for an embryologist. My embryologists do take a call, but it's generally for 2 to 6 hours. I would say we wait for the embryo to expand properly, and at least 80% of the blastomeres should have survived. Sometimes if the embryo is of a low quality, then we could have thawed it earlier only. We thaw it on the previous night. We allow it. Many a times, day 3 embryo transfers I have literally stopped, so I allow all the day 3 embryo transfers to grow for 2 days, become a blastocyst, and then transfer. But obviously, all these decisions are already told to the client that suppose I have only 2 day 3 embryos, there's a possibility I may not be able to transfer and nothing can go to blastocyst, but then doing blastocyst is better. So it's a shared decision making. Sometimes the patient says, well, doctor, I don't want to take that decision, transfer day 3. Or sometimes they would agree to thaw the embryo. The blastocyst, definitely all of us uniformly agree have a better chance of pregnancy.
So is there any specific embryo transfer catheter you recommend that this is the best? And
my favorite is Wallace. I wouldn't say best or not best. My favorite has been Wallace SureView, and the second is the Cook. And but nowadays the problem with the Cook is they're not giving the obturator. The obturator is out of market. So but still for the curved ones, I still prefer Cook, especially the acute retroverted ones. I do prefer Cook rather than doing any manipulation of the Wallace. Otherwise, Wallace SureView is my favorite.
thank you, sir. Thanks a lot.
Sir, excuse me, can I ask something?
Yes, madam.
Sir, what is the use of transvaginal, to do embryo transfer under TVS? Is there any special use? Why should we do and try under TVS? Why not? Abdominal is equally good, I feel. Why still people they are trying for TVS
What you say is perfect, madam. Absolutely perfect. The only reason I would think of doing a transvaginal is if I have an acutely retroverted uterus, which is abdominally just not amenable. You put an abdominal probe, it's a previous LSCS, the cervix is stuck anteriorly, and there's an acute retroversion, and you're getting a longitudinal view. It's an end-on view of the endometrial cavity. That's the only reason I would say that doing a transvaginal could be useful. Otherwise, even I really do. The
It
last
is very
transvaginal I must
cumbersome,
have.
very cumbersome.
Yeah,
One
very
thing,
cumbersome.
yeah,
That is not my practice at all. The
I know.
last transvaginal I must have done about 3-4 years back. I prefer doing our simple kind of transfers
Always
only.
better. Abdominal is always better. One thing more,
100%.
sir.
No
One
doubt.
thing more, is there any, do you use any antispasmodic or uterine relaxants?
No, ma'am. According to me, progesterone, a high progesterone is what is essential. So I
No
prefer. Okay,
antispasmodics.
I
No.
just give intermuscular progesterone in oil. That's the only time I give a progesterone in oil to all my patients in the morning of embryo transfer. In the afternoon, my transfers go.
No use of relaxants as well.
There is evidence. See, evidence will be published on either side of the story. But these are not RCTs. Most of them are cohort studies. So they would be there. And a lot of things are. I think there is too much of pharma in India pushing atosiban and pushing all these
Yeah.
things. Atosiban especially. Wherever there is good amount of profit, the pharma is bound to push it up harder and harder. I don't see there is much evidence. I've never used it, atosiban. Just then I should be having somebody using it. They should have phenomenally high pregnancy rate. But everybody has a decent pregnancy rate. I think.
Not of much use, you want
Not
to say.
much use. Yeah.
Okay, thank you, sir. Thank you.
Thank you. Thank you so much, all of you. Thank you.
Thank you, sir. Thanks a lot. It was indeed a great lecture and we learned a lot. Thanks a lot,
Thank
sir.
you. Thank you.
So now we move ahead to the next panel discussion that on the thin endometrium, how to manage it. So the moderator is Dr. Pratik Tambe, And our experts are Dr. K.D. Nair and Dr. Sonu Balara. And our panelist, Dr. Neeru Thakral, Dr. Puneet Arora, Dr. Ritu Jain, Dr. Pujil, and Dr. Swesha Khajirao. So may I request Dr. Puneet or Dr. Neeru can introduce Dr. Pratik Tambe.
Welcome, Dr. Pratik. He is a ART consultant and gynae endoscopic surgeon at Ashirwad IVF, Mumbai. And he's been trained in ART in Belgium, France, and clinical embryology at London and Singapore. And he's governing council member of ICOG and ICRM and MOGS, that is Mumbai Obs and Gynae Society, and committee member of ISAR, of MSR, past chairperson of Folksy Endocrinology Committee, and lots more to his name. He's recipient of 36 prizes and awards, editor of many books,
Thank
and
you.
four
That's it.
focuses.
Thank
Let
you.
me complete it, Dr. Pratik. It's quite a nice CV you have, and convener of ICOG Reproductive Medicine course and peer reviewer of Journal of Obs and Gynae of India, 2012 onwards. So welcome, and let's have a good interactive panel discussion on thin endometrium for benefit of our patients. Yes,
So
Dr.
thank you
Pratik.
very much, ma'am.
Yeah, you can share your slides.
Okay, should we introduce the other panelists and the experts before we go ahead?
Dr. Manju, do you want it or we can continue?
Yeah, you can introduce.
But this is Dr. Sonu. Sonu is
She can't introduce herself, obviously.
Dr.
No,
Sonu, let me introduce
yeah,
Dr.
let me introduce her. Dr. Sonu is our expert for today evening. She's presently Director ART Fertility Clinics, and she's the past secretary of the Haryana chapter of IFS. She was a unit head for 12 years at Artemis Health Sciences in the reproductive unit, and she's got the Best Chapter Secretary Award at the Fertivision. She's a graduate of the prestigious PGIMS Rohtak. So welcome, Dr. Sonu. And our second expert is Dr. K.D. Nair, sir. Sir is the senior consultant, head of department, Akansha IVF. And he has been the immediate past president of IFS. He's convener of the Education Society for the last 8 years and the chair-elect of ISIG ASRM. Sir is a thorough academician always. He has has 30 international presentations in the ASRM meetings and 27 in the ASHRAE meetings. And no ASRM ASHRAE meeting now goes without his presentation. So that is, I think, the most important part of his CV that I can read. Then we have our the panelists. I think for the panelists, do we have the CVs? Or otherwise, we can just introduce Dr. Neeru Thakral. She is the secretary of the Gurgaon Obs Gynae Society. Dr. Puneet Rana Arora, another very dynamic academic person from Gurugram, Dr. Ritu Jain. Dr. Ritu Jain also has been the past president of the Gurugram Obs Gynae Society. Dr. Pujil and Dr. Suesha Khanija. Dr. Pujil also is practicing in Gurugram and Rohtak, and Dr. Suesha is a young, budding, dynamic, and very active member of the Delhi ISAR. So I don't know who all are there because I think you'll have to find out, Dr. Pratik, because I can see
No worries, we'll
Dr.
address them
Manju
by
to
name, and
Dr.
if they are
Puneet.
there, they will answer.
Yeah. Thank you so much.
Thank you very much. Thank you very much, Dr. Jyoti Malik, for having me here. It's always a pleasure and a privilege to be with the other chapters of ISAR. And thanks, Dr. Jyoti and Dr. Meenu Handa, for inviting me to this wonderful academic event. There have been two excellent lectures, and a lot of what we're about to cover has directly or indirectly been addressed, which makes this panel discussion very easy for me, and it's going to be very simple and straightforward for the panelists as well. As usual, I like to begin with a few simple points to be kept in mind. Let's look at this from the basics onwards. Not everybody practices in posh, air-conditioned tertiary care. Some of us do practice in small nursing homes and smaller units where not all facilities may be available. We'll take 2 or 3 simple case scenarios. Evidence-based answers and precise answers are always welcome. So the first case is a 28-year-old lady with a 30-year-old husband. They're married since 3 years. They're trying to conceive since 2 years. She has irregular cycles. BMI is 30. So this is a PCOS. HSG shows patent tubes. TSH prolactin is normal. Semen analysis is absolutely fine. The problem is probably the fact that she has oligo and ovulation. Her previous cycle charts are showing thin endometrium of only 5 to 6 millimeters. And unfortunately, ovulation has happened only once. So how should we proceed and what options should we give them? Rather than dive straight into, tuberculosis and hysteroscopy, metroplasty, all those difficult things, let's start with the simple basic clomiphene resistance and anti-estrogenic action of clomiphene. So whoever wants to take this, you can go ahead. Dr. Puneet, ma'am, you want to start?
Yeah, okay. Thank you, Dr. Prateek. So I think you have already kind of given a nice start as to what we should do it to begin with in this case. I think there are some good points which are giving us a hint how to proceed. Irregular cycles and ovulation happened only once. These are quite striking points. And I don't know whether if she had a history of thin endometrium, whether she should have been given clomiphene, because that may give us a little biased view on the endometrium because of its effect on
Absolutely.
endometrium, anti-estrogenic effect. Maybe you could try some other oral ovulogents or
Excellent.
go for gonadotrophin stimulation just to see is it thin endometrium because of the anti-estrogen effect of clomiphene, or is it high androgens as the cause, or is it something in the uterine cavity which could be the cause of thin endometrium?
Correct. So the most common culprits are, of course, the hyperprolactinemia, hypothyroidism, which often run in parallel with PCOS. Many patients who are treated by general practitioners or common OBGYNs who don't exclusively practice fertility still have clomiphene administered to them, though we all know that the modern guidelines all recommend letrozole and aromatase inhibitors as the first line of management as far as ovulation induction is concerned. And then they keep giving cycle after cycle of clomiphene. Even today in 2025, being in a metro city like Mumbai, you'll be surprised that I get patients who are referred to me and they have cycle after cycle, first cycle 50 milligrams clomiphene, second cycle 100 milligrams clomiphene, third cycle 150 milligrams of clomiphene, no pregnancy, no ultrasound monitoring. If at all the monitoring is done, it's done by a radiologist with a transabdominal scan. It's not the same person scanning the patient from the first day to the last. And then finally, she is referred to a fertility clinic saying she's not getting pregnant, do something about it. So this, even in 2025 in major metros, can be, it completely stumps you. You are surprised that people are practicing ancient medicine from 30 and 40 years ago. So I'm pretty sure that if you go into the interiors of the country where, practices are not much up to speed, this is a scenario which will be widely prevalent. So having said that, what is the opinion of the panel on starting letrozole in such a patient? Do you want to start it immediately? Do you want to give a washout period? Are there some tests or investigations which you would suggest before we start with letrozole or any aromatase inhibitor for that matter? Anyone can take that.
So, Dr. Prateek, she is just 28 years. Maybe we can just leave her for some time and ask her to reduce her weight, focus on her diet,
Yes.
and then maybe she can come back and get reinvestigated and then start whatever. And maybe she conceives within that time.
So I think the pertinent approach here probably would be to start some form of insulin sensitizers. The guidelines all recommend metformin, though in clinical practice, all of us have been using myoinositol, dechiroinositol, and all these different agents which are available in our country for the past 5 to 10 years with varying degrees of success. Some of those are evidence-based. Many of them may not be evidence-based. They may be more, as I like to say, in inverted commas, experience-based rather than recommended by guidelines. But some form of insulin sensitizer would be recommended. Also, the guidelines clearly state that if a PCO woman is put on insulin sensitizers, the chances that she will have OHSS during the stimulation when you're using gonadotropins are significantly reduced. So yes, as far as the other agents are concerned, bromocriptine, cabergoline, dexamethasone, occasionally you see that these prescriptions are still being written in 2025. Is there a place for these anymore, or should we straight away just go to gonadotropins?
I think it'll be good to investigate them because each one has a mechanism of action, why it's being given. And there is a scientific basis of using these medications, provided we have investigated them fully. And it is found that anovulation could be because of high androgens or
Very good.
because of high prolactin or whatever it is. So I think
Perfect.
without investigations, I mean, in my practice, I generally don't go for it unless I've kind of thoroughly examined them, investigated them before I start all these medications.
Okay, so I think that hits the nail on the head that you need to have a good set of investigations. You need to have multidisciplinary team approach. Make sure that you've dotted your I's and crossed all your T's. Have a good checklist which lists out all the issues. Make sure that the male partner is re-examined. Don't always believe the semen analysis test that he comes with. May not be done from an NABL accredited lab. So those are the basics that we would like to address. Now, finally, the most important question of the day, and this is going to be a controversial point. Does anybody in the panel believe in giving follicular phase estrogen when there is a thin endometrium?
Are there any other panelists, or Puneet, you
I think there's only 3 of us, ma'am. It's going to be a
Okay.
conversation. Chai pe
Because
charcha
I
with
was
you.
thinking that I should not be in the discussion or something. So I don't believe it. Let me take it. Then maybe Puneet can also. I have never given follicular phase estrogen. That's what you want to know. And for this patient, maybe after, if she doesn't conceive in 6 months or 1 year and she's reinvestigated, she comes back, I will start her on letrozole, and then maybe we move ahead with the treatment according to the follicular monitoring and everything. But follicular phase estrogen, I have never given. Puneet, maybe what's your
Yeah,
take on?
so I would agree. I would never give estrogen prior to ovulation. I may consider post ovulation because I believe that is it the resistance of the endometrium to estrogen, or is it insufficient estrogen by the follicle? That they are the two reasons, could be the two reasons. If it is insufficient estrogen, maybe we think follicle 20 in a particular woman could be okay, but that's not releasing enough estrogens to grow the endometrium to a follicular phase. So I would wait. And sometimes if it is a resistant endometrium, you would maybe want to change your method of stimulation and see if it is still thin, then you would investigate why it is thin before jumping into estrogen supplementation. So I would say that, just to summarize, I may consider post-ovulation, but definitely not pre-ovulation.
Thank you. Thank you for underlining that very important concept, because many general OBGYNs, when they see the endometrium is 5 or 6 millimeters, when the follicle has already reached 18 to 20 millimeters, the first temptation is to give oral estrogen.
Yes,
And
there are
in
so
doing
many
that, they
prescriptions. Yeah.
may actually reach a good endometrium, which anyway it would have caught up in a day or two, maybe. But what happens is that they have poor oocyte quality as a result because of the negative feedback, and ultimately you don't get pregnancy. The aim of our
Yes.
stimulation is not to grow follicles and get oocytes, but to have pregnancies. And they
So the
seem
basic
to
physiology should be taught to the
exactly.
those people who are starting.
Exactly. So these are some very basic concepts, and it's all well known that ART outcomes very highly dependent on the starting BMI or the pre-cycle BMI. This is well known since at least 25 to 30 years. If you have a starting BMI of between 30 and 35, irrespective of which protocol you use, the outcomes are reduced by 30%. And if the BMI is more than 35, they are reduced by as much as 50%. Much has been said about metformin and lifestyle. You don't need me to come here and tell you that insulin sensitizers are essential in patients who have a BMI of more than 27, and they are definitely recommended in patients who have chronic oligo or anovulation. Cochrane meta-analysis says that aromatase inhibitors are very good, much better than clomiphene, and that's why DHA guideline recommends them as the first line therapy as far as ovulation induction is concerned. Let's go to the next case. This is a lady who's married since 7 years. She has secondary infertility. She had a previous first trimester loss and a DNC was done at that time. This was almost 6 years back. Subsequently, she's undergone multiple cycles of IUI. She's also had 2 embryo transfers done, and a hysteroscopy after 2 failed IVFs or embryo transfers has shown poor quality pale endometrium. And you go back and look at the cycle charts, you find the endometrium was only around 6 millimeters in both cases. So it's a spot diagnosis. But unfortunately, even in today's world, we do come across cases like this who have undergone a surgical curettage. It is beyond us to say whether it was indicated or not. It would be inappropriate of us to comment on it and blame somebody else that उसने तो DNC कर दिया, अभी आपकी बैंड बज गई है. We should refrain from those kind of comments. But what are the realistic options that we can offer this couple?
So, can I take this question?
Yeah, of course, ma'am. Please go ahead.
So, first thing is when we say it was a thin endometrium, maybe that along with functionalis, basalis has also been damaged. In first place, what
Excellent.
was the endometrial score when the multiple IUI or IVF was done? Probably it was not up
It
to
was
the
not
mark.
up to the mark.
It was not up to the mark. And when hysteroscopy and what was the like blood flow, and if we go according to the revised in the latest Appleworm score, whether it
So
was
can we say that maybe this is a case where we should have a low threshold for hysteroscopy? I have seen that a lot of fertility clinicians, especially the newer generation, they avoid pre-IVF hysteroscopy and any form of operative intervention like the plague. They just want to do their stimulation transfer, stimulation transfer. And they'll wait for 1 failed cycle, 2 failed cycles, then they will offer hysteroscopy to the patient because that is what is recommended by Western guidelines. But in India, the clinical scenario is very different from what you see in Caucasian patients.
yeah. So maybe, sir, when there was one failed cycle and we are not getting the adequate endometrial pattern, flow, and thickness, and myometrial flow and uterine flow, that time only we should have opted for hysteroscopy.
Perfect, perfect.
A diagnosis, whether it was a chronic endometritis or it was, overdone damage to the endometrium.
Overzealous surgical care.
Oh, yeah. And then looking at the endometrial quality at the hysteroscopy, it adds so many other things to the diagnosis, whether it is only
Okay.
pale or we find some other stigma, say, of chronic endometritis or
Right.
other and prevalent in our country, and then probably take the samples accordingly if needed, and maybe for CD138 and for tuberculosis if desired, then prepare the endometrium properly, and once we find according to ultrasound characteristic that it is now wise to transfer, then only we should have transferred, and we can have various agents used for that. So different measures like ecosprin or aspirin is there, arginine is there, high dose of estrogen which may be given transdermal or by the oral route, or we could have chosen, say, tamoxifen for preparing the endometrium, or sildenafil to build up. Nowadays, sildenafil has very good reports of improving the endometrium and high clinical pregnancy rate.
So let's
And
go in a step-by-step fashion. You've mentioned so many alternatives. For the benefit of the audience, let's start from each of these. Aspirin, what is the dose that you recommend? 75 milligrams, 150 milligrams, something in between?
maybe like recommended one is 81, but depending upon patient's weight, it can be
Okay.
increased 75 to 150 according to the
Okay.
BMI in our country, and it has to
And
be
when do
given.
you start and when do you stop?
It has to be given at bedtime. That is very important after dinner, and
Okay.
we give it like I started before, and we keep continuing or
So at least one cycle
before
before?
embryo. Yeah, two to three cycles till we find an appropriate result.
Okay. Or at least one cycle before. And you continue it until you get your beta HCG positive and then you monitor the patient.
Correct,
What
sir.
about L-arginine? There was one movement sometime about 10 to 15 years back where people said that L-arginine and sildenafil, this combination works very well. What is your personal experience? Someone else on the panel, please.
So I would like to say that I don't usually use any of the adjuvants,
Okay,
even
ma'am.
aspirin or L-arginine. According to a latest meta-analysis in 23 by Baresetta, they also have refuted the use of any of these adjuvants.
Correct.
I would agree with the high dose of estrogen and alternative routes of
So if I can just stop you
administration.
there for a second, ma'am.
Yes,
How
yes,
do
sure.
you define high?
High means like
How many
usually
milligrams per day?
maybe 12 milligrams, and
Okay.
then uh, using alternative routes like usually I give it vaginal and even transdermal.
Okay.
So those routes can be used for estrogen. And if we are doing an HRT cycle, we can prolong it also till we get a required, like even at 5 or 6 millimeters, we can transfer. But this patient has had 2 failed IVF cycles, but you have
Correct.
not actually mentioned the what quality embryos were there. So maybe
Embryos are good quality. It's
if
only
it
pure
was a
endometrium.
leukoid embryo, then, but still we can give her a chance. We should not refuse, even if it is according to less than 7, even if it is a thin endometrium, we can still give her a chance.
Okay. So the ideal endometrial thickness that one would aim for in an HRT FET cycle, Dr. Puneet, if you could enlighten us.
So yeah, I think thank you for pointing that out, because I was about to come in that we have all seen pregnancies at some point in our careers, pregnancy at 6 millimeters, and I think
Yes.
sometimes it's the thickness, but sometimes it's the receptivity we should always consider, and I think these are all agents where the evidence, we cannot have like randomized control trials, not good quality randomized control trials in all these regimens. So we all have level 5 evidence. We have our personal experiences. We have our own data in this, maybe less cases, but
And most meta-analysis would say that most of the options we offer our patients are useless. But then we have to offer them
useless.
something.
Absolutely, absolutely. Because if we go to these evidence, and I think that's why they kind of our experience really comes into this, where a particular thing will work. Like I have a case where recently, so a very similar case what you have, Dr. Pratik, you have pointed out, and it was a very pale endometrium on that. I did give her aspirin. I also did. I would say I do a lot of receptivities check,
So
endometrial
we'll come to ERA
receptivity.
in just 1 or 2 minutes.
Yeah. So, and I found that after aspirin, I did find a change in the receptivity pattern and she got pregnant, right? So again, like I said, we all may have different experiences with these agents, more or less. Yeah.
So ideally, we would
So I
all
would like
love
to.
to have an endometrium of at least 8 millimeters before we do an embryo transfer. But these kind of patients who have had previous surgeries, they have chronic endometritis or genital tuberculosis. Many of these patients struggle to reach even 7 millimeters. And even that 7 millimeters is not a complete trilaminar 7 millimeter stripe, which we see in textbooks. We are lucky if we get, one small little half or 1 centimeter patch somewhere in the entire length, which has struggled to reach 7 millimeters. You can make out that there are still synechiae somewhere or fibrotic bands, or the subendometrial blood flow is all disturbed. And in these patients, it's very difficult to give a result, you know. And we would love to have those 8 to 10 millimeters, but unfortunately, in most of these patients, despite all the masala that we add, despite how much estrogen we add, how much low molecular weight heparin we add, sildenafil we add, they struggle to sometimes even reach 7 millimeters. Having said that, does
Dr.
anybody
Pratik,
have any experience with
Dr.
transdermal?
KD Nair is also there. Dr.
He's
Pratik,
there.
he's there.
Okay,
He can
fantastic. So
take his
let's have
comments.
Sir. Fantastic. I think Sir came in late and I didn't
Yeah,
see.
yeah.
yeah.
He's going.
Yes,
Dr.
sir.
Pratik, can I
Yes,
comment?
sir.
You see, I
Of
was
course,
listening
sir.
to all this additive.
Yes, sir.
This, I have experience of using PRP in such cases. Yes, this patient had previous 2 cycle
So
of
we're coming to PRP in just 2 minutes, sir. 2 minutes.
Okay.
Just hold on. I
Yeah.
wanted to do the routine stuff first and then go on
Yeah.
to ERA, PRP, PBMCs, all that. So if I can ask the panel, does anyone have any experience of administering these, alternative means, sprays and gels of estrogen? And do they actually make
Yeah,
a difference to your patients?
yeah, sir. I do use in my practice the other route of estrogen therapy, and I find it very effective, in fact. And many patients have intolerance taking high dosage of estrogen oral
Okay.
estrogen. So I prefer to combine with oral estrogen, say 2 milligram twice a day, along with transdermal therapy, maybe in the form of gel or the form that is available. So
Okay.
I prefer adding both to get a good endometrium. And in fact, whenever there's a very thin endometrium, everyone tries one's best modality available to get, the best endometrial lining and scope.
Okay. So in your experience, it has worked, but the cost of the therapy sometimes, poor patients can't really afford. Somebody mentioned ERA testing. So let's go back to endometrial receptivity arrays. Does somebody, or I think Dr. Sonu mentioned that.
No, I think Dr. Puneet,
Dr. Puneet,
I don't,
Dr.
I
Puneet
don't do
mentioned.
ERA at all.
Okay, you don't do ERA.
I'm not a fan of
So
ERA.
for the benefit of the audience, can you please tell us what is this ERA testing? How is it done? When is it done? And finally, how do we interpret it?
So basically, it's a genetic test on the endometrial genes responsible for receptivity. It tests around 200 plus genes. And we all know that the receptivity comes in through progesterone, and the receptors are made by estrogen. So again, we need a good kind of a mix of adequate estrogen therapy and progesterone therapy to give us a good receptive endometrium. So this
We
is
are
what
trying to identify what is called window of implantation. And
implantation,
this,
that's right.
contrary to popular opinion, actually happens about 7 days after ovulation, 5
Ovulation.
to 7 days later,
Yeah,
which is
LH
not
plus
something
7.
which is commonly known by a general gynecologist. So
That's
it
right.
comes as news to them, when you talk about this to them.
Yeah, so LH plus 7, we generally count from the, the LH surge, or if we are starting progesterone, it's 5 days after starting progesterone. That's the time when the window of implantation is there, and the endometrium is kind of called as receptive. So the concept is just based on finding the ideal window of implantation where, we feel that implantation can happen if it's not happening despite repeated transfers and, therapies.
So you would do a small endometrial biopsy, send the material for testing, and how much is the turnaround time? When can we expect the report?
Generally 2 to 3 weeks it takes
So
for
which
the
means that
report.
we can't do the transfer in the same cycle.
Now, generally, if you're doing a hormone-based cycle, it takes around 2.5 weeks to build up the endometrium. By the time the
Okay.
endometrium is ready, we get the report. But if you're
Okay.
doing a natural cycle or LH-based receptivity, then it's a little tricky because, every month we can have a little variation on the LH surge. So generally, I give a gap if I'm doing a natural cycle receptivity check.
So if you time your embryo transfer in alignment with your ERA testing, how much better clinical pregnancy rates can we expect? This is what the audience wants to.
So I think that's a very tricky question because we are not doing on every patient, right? And
Correct.
we don't have a comparison, right? So we
No.
are doing
And it's
on
impossible to do an RCT in such a case.
RCT on it, right? So I would say that it's very difficult to answer how much above because I've not done on a baseline population, a normal woman who has not been able to conceive naturally and is undergoing IVF and do ERA in everybody, right? So because that will be my base in case I want to comparison how much is the rise in the pregnancy rate. But I do feel that in some cases where you are looking for answers, where you have done everything right, you have a good endometrium, good embryo, beautiful blastocyst you are putting in, and maybe you have in some cases done the genetic testing on the blastocyst, all euploid embryos. So you just endometrium is good, it's trilaminar pattern. So in those cases, I would say I do reserve, endometrial receptivity window of implantation check for such patients.
And they would usually sooner or later give you better clinical
Better
pregnancy rates
chances of
once you have sufficient numbers.
So
numbers.
With
Dr.
small
Pratik,
numbers, it may not reflect.
yeah,
Yeah.
I would like to comment that if we
Yes,
do ERA in the one particular cycle and we do it again in the next cycle, then maybe the window of implantation they
window
give
may have shifted, may have changed.
So actually we are doing it in one cycle and then the next you don't know whether it's the same window of implantation.
It's one of the major
Yeah,
controversies
exactly.
regarding ERA
And
testing.
and there are so many people who are doing FETs for blastocyst at +6 and +7. So that also refutes the actually that era has got some maybe like some people uh, take benefit from that, but actually not. I'm not a very
I
big
would
fan
just
of
say
it.
that there is a good evidence to suggest that the hormone profile of the endometrium doesn't change much for 3 to 6 months. As
Yes.
long as you do it
Yes.
sooner, you can
I
still
see we have Dr.
extrapolate.
Sachin Kulkarni
So
with
these
us.
are all
He raised his
controversial.
hand.
Yeah.
I think, yeah, we may not agree on it, all of us. Yeah.
Yes, yes, exactly.
It
Yeah.
is
Yes,
little
sir.
controversial.
Let's hear from you, sir.
Pratik, thank
Yep.
you. Thank you for allowing me. Thank you for allowing me a sentence. Yeah, firstly, I think if you look at the era, go by the study by Cozzolino et al. The person who developed the whole ERA test at the Zigmo group and the Carlos Simon group, in their own study, when they did an RCT with a personalized embryo transfer and non-personalized embryo transfer, it did not work out. So it did not make any difference of doing ERA to anybody. Many a times, a lot of people do ERA for a closure of a case. Like, well, we have done everything.
So
That
true.
kind of
Yes.
attitude.
Yes.
But I feel a closure of a case is better achieved rather than ERA by doing an euploid embryo transfer. Because if you are facing a lot of problems with endometrium, why not improve the embryo? And you're getting helpless and not get great scientific evidence. Again, going back to the Barisetta study, which just was quoted, if you go by the Barisetta study of a retrospective analysis of endometrial thickness and transferring single euploid embryo from 4 to 12 millimeter, they consistently had 40 to 42% pregnancy rate. So why not take that as a treatment of choice for your refractory endometrioms, and then rather than doing all the masala kinds of stuff. That's why I've practically stopped doing masalas. I prefer just doing, and there's one study, it's an old study, not replicated, but this was very much promoted by Dr. Jyoti Kumar from Singapore, wherein this is a Chinese-based study, wherein they used a high dose of estrogen, 12 to 16 milligram per day, and maintained the estrogen level of 600 to 800 picograms for a period of 2 to 6 months. Don't ask me about thrombogenicity, that they never reported in those studies. But their ethos was keeping the estrogen such a high could have a stimulatory effect on the progenitor cells on the endometrial basalis, which are ultimately stimulated by estrogen, and that could make a difference. So many times I do use that, but I am not a daredevil to use 12, 16 milligram. I prefer using 4 milligram a day, continuously, uninterrupted for 3 to 4 months. Do I get good results? No, I wouldn't say that. I've hardly used for a handful of patients. So I wouldn't say anything, but that could be one. But the best, as the evidence stands today, is to transfer euploid embryo transfer.
So I
So
think we
I
can
would like to.
summarize by saying that most of these alternatives that we are offering our patients may not have very good large volume robust data. There are thin margins. There are very slim margins, and often if you look at tests of statistical significance, they may not meet those tests of statistical significance. Ultimately, what works for you in your practice, in your particular case, may finally be experience based and may not be evidence based. This is just one of the options that we are offering our patients who have been running around from pillar to post trying to get a pregnancy. Let's bring Dr. Kedinaya sir back into the discussion. Sir, you had mentioned stem cell therapy and you had mentioned PBMCs. So let's hear from you. You're the expert on the panel. Can you please unmute?
Yeah, I am not favorite of stem cells. What I did was, we had presented our study in PRP. In the
Yes,
last SRM, we have presented our study. We are giving in such cases 3 doses of PRP, day 7, day 9, and day 11. And we
Okay.
found it to be having a very good effect on endometrial thickness. And even if the endometrial thickness does not go up to 7 or 8 millimeter, the receptivity changes. The receptivity of the endometrium changes. There have been 2, 3 recent publications. They remove the 6 millimeter, 6.5 millimeter endometrium. The receptivity changes, and you can get a good pregnancy rate in such cases.
Thank you, sir. Thank you very much.
Is which is easily available to us. Stem cells is not easily available, and people who talk about stem cell, they have to be very sure how they have the lab requirement for stem cells or not. But PRP, you can do it in probably all of the lab IVF centers. They can get PRP.
I agree with sir. I am also using PRP very frequently for thin endometrium. And sir, I am injecting it subendometrially also after
To hysteroscope?
hysteroscopy and doing lateral metroplasty also. And
There's
I
one
am
very practical question that I've always had. When you're doing hysteroscope, the fluid is being put in under pressure. Even if you were to use simple IV fluid bag without using a hysteroplater pump, still, what are the chances that when you inject, it's not going to get washed out of the system?
So we give it subendometrially and lower the pressure when we inject, and then after injecting, just close. Those patients whom I'm not doing hysteroscopy, there I am injecting with IUI cannula. But when I'm doing hysteroscopy, I prefer to give it subendometrial, and I feel it works. I don't know.
And how do you
Yeah.
follow up the patient
And
subsequently?
with the ultrasound monitoring, sir.
Okay, so do you do simple 2D ultrasound or do you do
No,
3D
sir.
or do you do color Doppler?
No, color Doppler and 3D all.
Okay. So on your color Doppler, you would look for increase in subendometrial blood
Yes,
flow.
sir. Yes, sir. I do believe it comes to zone 3 and zone 4.
And on
And the
3D
number of,
ultrasound, you would look for the cavity, you would look for the
yes,
shape, you
volume
would look for
also,
the
endometrial
thickness,
volume.
volume.
Yes.
And
I
all
feel,
these parameters, when you put together in your supercomputer brain, then you decide that, okay, now perhaps this is the time, this is the best that we can achieve in this particular patient, and we should go ahead and do the transfer.
yeah, and PRP has anti-inflammatory effect also, and as sir
Very
said, receptivity. And
Yes.
doing it like in the subsequent cycle, only most of the time we are able to transfer the embryos.
Since we are on hysteroscopy, a lot of endoscopic surgeons advocate lateral metroplasty for patients who have poor or thin endometrium. We are not talking specifically about this case where there is a clear-cut endometrial injury that has happened in the form of a curettage. But patients who have persistent thin endometrium, they advocate lateral metroplasty as one of the surgical modalities which might help. Similar to, 10 years ago, there was this movement towards endometrial scratch therapy. What is the opinion of the panel on this?
Sir,
Dr. Tulip, want to take that?
Yeah,
So-
so I think, sorry, is it for me or Dr. Ritu?
Yes, ma'am. Yes, ma'am. Please go.
Okay. So lateral metroplasty, I think, again, like you rightly pointed out, Dr. Pratik, when we kind of inflate our cavity, even if it is sometimes on HSG, you see that, the cavity of the uterus looks
Lateral walls are convergent.
intending, yeah. And then in that case, definitely you would consider doing a hysteroscopy. And if you find the same findings on hysteroscopy, you would do lateral metroplasty. But again, I think it's important that if we are saying that, side cuts and lateral metroplasty should be done, it should be done in good hands, because I have seen a lot of cases where uterus has been adhered because of the lateral metroplasty, and it has led subsequently to Ashermans and adhesions in the cavity. So I think it's important to do it, but not to overdo it. It's just to do it as a for right indication. If it is really
And as
seen,
far as possible, not use electric current.
electric current,
Use
yeah,
cold
and
scissors.
cold scissors.
Make
Yeah,
sure that the depth of your thickness is not more than
is
1 to 2
not.
millimeters, because you could very easily enter the uterine vessels if you're not
Absolutely.
careful.
Yes.
So it
Yeah.
needs a good experienced surgeon, and it needs a judicious clinician to make sure that it is offered to the right patient for the right indications. Having said that, ultimately your mileage is going to vary. Which patient will respond, to what extent they are going to respond, is not in your or my hands. We'll go back to the concept of ERA testing, because we missed a very important question there. How much does it cost to the patient finally?
35,000 or something.
40,000. So that's a significant cost to the cycle. And
waiting
course,
for one cycle then.
yes, and unfortunately, what happens is that you have only two new options that you can offer your patients. One is ERA testing, the second is PGT, and both seem to cost at least 30 to 40,000. I think PGT costs at least 20 to 30,000 per embryo in a good center when it is done properly. Anybody has any experience with stem cell therapy?
No.
Not really. And I think we had a very
Pratik,
good.
I would like to add what Dr.
Yes,
Sachin was saying
Yes,
about the estrogen level. So in our group, we are doing the estrogen levels like before we start the progesterone. If we see that the endometrium is thin, or so I always keep it above 150, and even in failure patients, we've had a good result with that. So
Okay.
doing an estrogen level before we start. If it is low, then we may change the route of administration or add estrogen for 3-4 days, and then again do it. And then later on, if the level is good, then we start with the progesterone.
So this again brings us back to the original question of whether we should, forget about all these, crazy HRT, FET cycles, which we've been doing for 20 years, and go back to the basics and start doing natural cycle or modified natural cycle FETs, do you think they would represent a much easier way of stimulating, monitoring, and then doing the transfer with consistent reproducible results? Is that what we should all be moving towards, at least in this group of patients, maybe?
So for those patients, it is a very difficult, like you have to choose the patient who have a regular cycle and who have a normal uterus. There is no adenomyosis, no other factor, any uterine factor. So the selection of the patient is very important to do a natural cycle FET.
Okay, and when we talk about natural cycle FET, does it simply mean that you call her just for follicular studies and wait till she ovulates? And like Louise Brown, 36 hours later, you do the embryo transfer, or there is some intervention that is required on our part? That's
Multiple
very
blood
important for
tests
the
are
audience to
required.
know.
Maybe sir can take the answer, but multiple blood tests are required and a very strict monitoring is required. So it is quite a difficult like monitoring for the patient, and cost also, and everyday visits to the clinic. So that is maybe sir can
God
give us
forbid,
more
if you
insights.
trigger on Friday and your transfer comes on Sunday, then you had it. Your embryologist will not get
True, true.
I think
That way modified
it's
natural better.
little difficult for patient and difficult for the doctor.
Even more difficult for the embryologist.
Yeah, difficult in that sense. So you have to be very clear when you're planning a natural cycle.
And you need to have an ongoing program. You can't do batch
Yeah.
IVF with natural cycle FET and modified natural cycle
So
FET
our
because your
group, we are doing
embryologist is
it.
not
We are doing it quite frequently, but it is quite exhaustive.
It's quite cumbersome. It's
Yes.
not as easy as it sounds.
Yes.
And probably the reason why HRT FET has stood the test of time is because it's very easy to learn. Learning curve is small. Even new clinicians can pick it up very quickly. There isn't much intensive monitoring required. It's quite easy to replicate and reproduce, even if you're doing, say, 50, 60 transfers in a month, as opposed to the amount of mental trauma that you have and the amount of effort that you have to put in into monitoring a natural or a modified natural cycle if you're doing a large number of transfers. Of course, we talked about the availability of embryologists as well. ERA again is used to personalize the window of implantation, but current data, as per the systematic review and meta-analysis published in Human Reproduction Update, says is insufficient. EMMA, ALICE, and DICE are the various tests which are now available. We've talked about ERA, but we don't know whether it is something which is going to benefit our patients consistently, patient after patient. LMWH, all of us have used for at least 20 to 25 years, truckloads of it. But unfortunately, meta-analysis says that you get identical implantation, clinical pregnancy rates, and live birth rates, though even today, many of us still use it for whatever little benefit it may give. Does anybody have any experience with these drugs? They are actually agents which are supposed to help the immunomodulation process, which of course we know dydrogesterone can do, but when you have an excess of these natural killer cells and interleukins and cytokines which are there, then agents like this tacrolimus might help. Anybody has any experience with these?
No, they're still not popular in India.
Yeah, so I think this is only in patients with recurrent implantation failure, and immunotherapy specialists recommend these. We don't have much experience, but the evidence is something which is startling. 45% versus 0% implantation rate and live birth rate of 60% versus 0%. And this is from a Japanese group published in 2015, specifically for women who have an elevated pH1 versus pH2 ratio. Again, the jury is out there. You will not get large systematic reviews and meta-analyses on these kind of agents, but they do seem to be of some benefit. Again, IVIG therapy, there are many people who simply swear by it, especially if women have elevated natural killer cells and those CD56 cells which are there on immunohistochemistry. Again, clinical pregnancy rates and live birth rates seem to be better. We've already talked about PBMCs and stood the test of time, consistently good results in most patients. We know how the procedure is. For reasons of paucity of time, we're going to skip ahead and go to the next case, GCSF, varying results. Interestingly, GCSF, some of my patients were very surprised when I gave GCSF intramuscular, because previously in other clinics where they had gone, they had always received it as an endometrial, direct injection with maybe an IUI cannula. They were very surprised that if you're giving intramuscular or subcutaneous GCSF, how does it go and work on the uterus? But the theory is always that whichever the rapidly multiplying cells, that is where your GCSF is going to act. Summary of interventions. Last case is a patient who has chronic endometritis. I'm cutting to the chase because we've run out of time. I want one quick answer from each of our panelists telling us how you would tackle this patient.
So in this case, it is very important to treat her pelvic infection. The
Correct.
cervix, it is an ectropy and a vaginal discharge is there. The complete
So
course
as a
of
corollary, can I
antibiotics
say
for
that all patients who have had euploid transfers, thin endometrium, recurrent implantation failure, always should be investigated for chronic endometritis?
yes, even after
Can we
once,
make that as a mandatory requirement in our clinical practice? We take
yes.
it for granted.
I feel we should treat and look for chronic endometritis before we take up any patient, because per speculum examination is there as a routine. So we know like what kind of patient we are going to deal with. So take the pap smear as in routine before for all the infertility patient, and that time. And when we do transvaginal scan, we know and look for any infection. And there are ultrasound features of chronic endometritis also. So it is better to pre-treat even before the first transfer, not to say for recurrent implantation failure or so. So I prefer swab and culture. I prefer to do when I see the infection, and when I give doxycycline for 2 weeks, and then metrogel also. And pre-probiotics is also something which we always give these patients,
So
because
Dr.
that
Puneet, what
pre-probiotic.
would be your poison of choice when it comes to prebiotics, probiotics? There are so many of them. Some need to be refrigerated, some can be kept at room temperature. There are a million different strains that the companies come and confuse us with. So what is your agent of choice?
So again, you rightly said that there are a lot of regimens available for probiotics, but I think it's the diagnosis first is important. Has the women got an altered microbiota in the endometrium? And again, there are a lot of studies to say that, is it the microbiota if we test from the vagina, is it going to reflect the endometrium? How do we take the microbiota of the endometrium? Is it those Ellis and Emma tests we do? So again, there are a lot of controversial statements on this, and we still don't know whether we should apply. They do come with high cost and all. But if we just come to endometritis, simple histopathological diagnosis, CD138 is something, which is used commonly. But again, there has been little controversy on how many number of plasma cells do you see to diagnose CD138 cells do you see and all that stuff. But yes, if you have, a history, a thin endometrium, ectropion, cervicitis, I think she definitely needs treatment for infection and pelvic infection, like Dr. Ritu rightly said. And a proper PID course of 2 weeks should be given to these patients. And I think we have seen, all of us may have seen a change in the results in our patients. Yeah.
So the uterine and the cervical microbiome, making sure you aspirate that cervical mucus, making sure that you've treated the patient before she comes up on table. These basic things which we often take for granted, these are still very relevant in Indian clinical practice because many of our patients do harbor pathogens. Many of them may be antibiotic resistant. They may have received incomplete courses earlier, and you can see the results. Improvements in live birth rates are almost 60% versus 30%. And live birth rates, even natural conceptions, are significantly higher with the simple act of treating chronic endometritis. You may not even need to add all this new masala, prebiotic, probiotic, which the companies are trying to shove down our throats. So thank you very much, everybody, for a wonderful panel. We'll have closing remarks from our two experts, Dr. Sonu and Dr. K.D. Nair, and then we can close the panel.
Dr. Pratik, I just like to mention when we're talking about prebiotic and all those things, we had attended a conference. This speaker from Sweden was there. I have forgotten her name. They have been using this vaginal flora from healthy females and transferring it to the women with the abnormal flora, and they have found that it works. And that is the thing which is going to come up probably in future. When we are talking of prebiotic, we have to ultimately shift from oral, the prebiotic which we are taking, we have to shift to something like vaginal, which works in the region where it is supposed to act. That will probably come in future.
Thank you, sir. Thank you for those words of wisdom. Dr. Sonu, closing remarks from you, ma'am.
So, Dr. Pratik, we have talked about the endometrium. So, thin endometrium, we cannot define whether it is less than 7, less than 6, less than 4. So, if it's a good triple line endometrium, we can go ahead with the transfer. And there's one more thing I would like to add, that our group is doing histro wash also. So, before starting the HRT, we just do sort of a hysteroscopy, but we do not take the scope inside. So just keep it at the internal os. Just close the tap and open the so that it is washed 4-5 times. And after 3-4 days, we start with the estrogen. So
If
we
you
are
remember the 1980s textbooks, they used to call it hydrotubation. They used to do
exactly.
it with the
So
college and you'll have that.
regularly we are doing that histro wash. It sorts of creates an aseptic inflammation, and we have very good results with that. So that
Awesome.
is in HRT cycles we are
The
doing.
old ways return in new forms.
Yes, just changing the name and giving it a fancy sort of a thing.
Visual. It is visual now. Earlier it
Yes.
was just like non-visual, just
Yeah,
text.
Thank
true.
you very much. Our
So
wonderful
what you were
experts
saying,
and
that
great
low
panelists.
threshold of hysteroscopy, I think everyone should do that.
Thank you very much. And thank you,
Thank
Dr.
you so
Jyoti
much.
Malik and the Haryana chapter for having me. It was wonderful being with all of you. Look
Thank
forward
you.
to interacting with you soon.
Thank you, sir. It was nice interacting with
Dr.
you.
Pratik, you always make the discussion so very meaningful. And that is why it was really, I preferred that you should be moderating this, because you take the whole situation, like right from beginning to how to advance and how to, we spoke about small little things, and then ERA, and then hysteroscopy and metroplasties and stem cells, and then again coming back to normal, the natural cycles. So it was wonderful. There is a small little question. Day 7, 9, 11, somebody was a little confused. Dr. Nayar's protocol of giving the PRP. So if you can just repeat that again for the sake of our audiences. There was a question there. They could not understand that. They wanted to elaborate to elaborate on this protocol. Dr. Nayar, sir.
I think he's
Day
in the
7, 9, 11, they did
Yeah.
not understand how you
Yes,
do
Jyoti, sorry, you see, I was busy.
it. Sorry, sir. Yeah.
Protocol, I explained. I did give it on day 7, day 9, day 11. 3 days we give, and we have found a good result. We have presented our finding last year in ASRM also.
Do you give it alone, or do you add GCS SF?
No, we only give PRP.
Only PRP.
0.5 ml PRP, nothing else.
And if the endometrium does not grow, still you go
You
ahead
see,
with
even if
the
endometrium
transfer?
goes up to 6 to 6.5 and it is triple layer, what happened with PRP, it improves the receptivity also. There are 2 very recent publication. They say the receptivity improves in spite of endometrium not going 7-8 millimeter, endometrium receptivity improves. So the chances of embryo sticking up is increased. Implanting the embryo is increased.
Right. So thank you so much. Thank you, Dr. Nair, sir, Dr. Sonu, Dr. Puneet, Dr. Ritu, and Dr. Pratik for an amazing discussion. And also, I would like to thank the 2 speakers, Dr. Sachin Kulkarni, sir, and Dr. Tejashree, and all the chairpersons, and also the delegates who joined for today's session. Thank you, Jagsonpal, and thank you, Nimisha. Over to you. Thank you.
So with this, I would like to thank everyone for joining in today. Indeed, it was a very wonderful session. And the session was brought to you by Jagsonpal Pharma, makers of Endorec, Divartron, and Maintain Injection. And thank you, and we look forward to your participation in the next webinar. Thank you, everyone.
Thank you.